This background is there in the mail? Sorry,
Yeah. Yes, yes.
let me check.
We are live.
Okay. So I begin. Good evening, friends, and a happy Makar Sankranti to all of you. AIS ARC has been doing various webinars on varied subject, and this is the 7th episode of our new team. Ophthalmology now is a specialty medicine, but per se it has evolved so much that now multiple subspecialties are challenging the concepts and practices which we learned more than a decade back. But there is still a dearth of subspecialties of subspecialists in of ophthalmology across the country, and still 90 to 95% of the subspecialty work is shared by our friends comprehensive ophthalmologists in the periphery as well as in the majority of the towns. So was the need felt to revise the subspecialty topics with our comprehensive ophthalmology friends. In this new series, we have collaborated with various subspecialty societies of our country to evolve such webinars which will be helpful to our friends, comprehensive ophthalmologists in the periphery or in any other place seated. I'm really thankful to President Dr. Shubhangi Bhave Madam, Secretary Dr. Pandey Sir, and Editor Dr. Rishikesh for helping me in crafting such program and a unique program which will be helpful to all the comprehensive ophthalmologists across the country. Also, for the very first time, we are introducing what is called Saransh. Practitioners like us who have not necessarily an access to the latest journals, and neither probably we are inclined to go through the journals to pick up the new concepts which are helpful in day-to-day practice. So here we have introduced for the first time in our country through AIOS a ready-made platter of articles, fresh from the pan, I should say, from the journals for you to accept and imbibe in your day-to-day practice. I'm really thankful to Dr. Krishna Prasad for from Hubli for making this particular first episode and making special efforts for this particular Saransh. My special thanks also goes to all the speakers, debaters, and my co-colleagues from ARC. And today's co-moderator are going to be Dr. Rishikesh Mai, and from Team ARC, we are going to have Anaga Herur and Deepak Mishra. So without much ado, I would request Dr. Anaga Herur and Rishikesh Mai to take forward the further proceedings in this webinar. Before that, before they start, I would request President of Palsy Society, Dr. Shubhangi Bhave, to address the gathering, and then we'll begin. So, Bhave, madam, please.
Yes. Thanks, Dr. Prashant, and Happy New Year and Happy Sankrant to all. The purpose of this webinar is to put forth the topics of our subspecialty to the general ophthalmologist. So we have chosen topics which are faced by general ophthalmologist on a day-to-day basis. And some of them, if they can start treating by this webinar on their own, that would be great. And I thank Dr. Prashant for taking this initiative, and as per his wish, we have chosen the young budding pediatric ophthalmologists from all over the country. And I hope everyone gets benefited from this webinar. Thanks.
Yeah. Thank you, Dr. Shubhangi ma'am, and welcome to all our viewers to this very unique webinar and a very interesting one at that. Lots of take-home points. So I would request each one of you to listen to all these talks because they are being basically given by our young colleagues who have got now a wonderful opportunity to teach all of us how we are going to deal with children. So this is a subspecialty webinar for Pediatric Ophthalmology for All. And we would like to thank the Strabismus and Pediatric Ophthalmological Society of India to that they have collaborated with AIOS ARC and for this wonderful webinar. So welcome each and every one of you. And thank you, Dr. Shubhangi Bhave ma'am, President, and Dr. Pandey sir, Secretary, for being here. And Dr. Rishikesh and Dr. Deepak would be my co-moderators. So, Dr. Rishikesh, shall we start with the first talk? So, we'll be having talks initially first.
Yes, ma'am. We'll start. Welcome all. Welcome.
Yeah,
all
Dr.
for this.
Pandey sir, welcome. Thank you on behalf of ARC for being a part of our webinar and agreeing for this new concept which we are trying to introduce on behalf of ARC. Thank you, sir.
Thank you,
Welcome,
Dr. Prashant.
sir.
It is a great, I think it's a very laudable effort and a lot of effort has gone in, and I think it's a very good beginning and we should work upon it. I think it's going to be very useful to the, pediatric ophthalmology subspecialty in general. Yeah, I think let's begin now.
So the first talk is by Dr. Aditya Sethi. He will be speaking on how to deal with ocular allergies in children. So I'll request Aditya to share his presentation, please.
Thank you, sir. Thank you, Dr. Rishikesh, sir, Dr. Prashant, sir. Thank you for having me here. So I'm going to talk about how to deal with ocular allergies in children. So without much ado, I'll start. So I'm going to break this up into introduction, diagnosis, management, complication, and what's new in treatment and management available. So introduction, allergic conjunctivitis is basically a response of a sensitized conjunctival tissue to all allergens. They could be fomites, they could be any sort of polluted allergens, anything that comes to the conjunctival tissue. Exposure to allergen leads to a mast cell degranulation that will lead to histamine release, activation of downstream inflammatory cascade, which could be type 1 or type 4. And it peaks in late childhood and happens in young adulthood in most of the cases. This also is often missed or underdiagnosed. So that's something that we have to put a fair share of light on. So this is how the pathophysiology looks like. So types of allergic conjunctivitis can be based on pathophysiology or clinical symptoms and signs. It could be IgE or non-IgE mediated. These are the broad types of ACs that we know of. We know the seasonal allergic conjunctivitis, which is basically type 1 or IgE mediated. Perennial when it happens all year round. VKC is the more acute or more severe form. AKC is like the atopic dermatitis of the eye and often is with bilateral lid involvements as well. GPC is more of a, it's more classified as a non-allergic sort of allergy, where it's because of micro traumas, which could be because of a contact lens or any other foreign body. And CVC is basically contact blepharoconjunctivitis, which happens because of medications or anything going inside the eye, which causes a bit of a reaction. So these are the various different types of allergic conjunctivitis that we know of and different allergens which cause them. Very nice table which summarizes most of the allergic conjunctivitis that we have to focus on. And as we can see, most of them are type 1 sensitivity, hypersensitivity. The VKC and AKC, which are more severe, are also type 4 or T cell mediated. Giant papillary conjunctivitis, again, something we have to know is more of a micro trauma than an allergy. So this is taken from one of the articles that I referred to while I was preparing this talk, and it talks about how rampant this is. And 1 in 10 children actually have AED, and if you actually go through your EMR of your hospitals, you'll notice that about 40 to 50% of the problems which the children come with is actually allergic conjunctivitis, and often it's the papillary type. And it's more common in boys than in girls because eye rubbing is more often there. Few misfacts on ACs are often bilateral, often self-limiting. A lot of patients take over-the-counter medications for this, which is something that it often goes unreported on. There's strong association with allergic rhinitis in a lot of cases, which is called rhinoconjunctivitis, and needs to be treated with systemic medications. There's also neuropsychiatric and behavioral issues which can happen along with this. The quality of life actually gets affected with allergic conjunctivitis, and it's often not documented. And over-the-counter medications actually have long-term side effects like cataract and glaucoma, which can happen. And the economic impact of the disease is quite severe. So diagnosis, the first thing you have to ask is the right questions. If you don't do that, you'll misdiagnose it as infective conjunctivitis and start treating it. So these are batch of questions that you need to ask. A lot of clinical features that you have to watch out for. The most common symptom is itching. Other are redness, watering, foreign body sensation, ropey discharge, photophobia, and drooping of lids. The most common signs are papillae, which could be tarsal limbal. You can have the Horner-Trantas spores, the Maxwell-Lyon sign, the perilimbal pigmentation, corneal epithelopathy, which can also be there. Complications can often present as sheath ulcers or limbal stem cell deficiency, keratoconus, and if medical treatment is taken for a long time, it can lead to cataract and glaucoma. So these are differential diagnoses that can be mistreated as allergic conjunctivitis. So allergy testing is now becoming more rampant in children, especially in urban areas. Skin prick test is still the gold standard, and it basically looks after the IgE levels and mediated allergic reactions. There's something called serum specific IgE, which is another marker. Non-IgE mediated allergic reactions can be done like the use of patch tests with desired battery. Other tests like CAPT, total tear IgE levels, allergen specific IgE, and cytology, impression cytology, is also has been studied and is still coming up. Clinical signs could also be tarsal papillae, which are histologically hyperplastic conjunctival epithelium with fibrovascular core and presence of eosinophil mast cells. A multiple confluent of them are called cobblestone papillae. Pseudomembrane on papillae is the Maxwell-Leon sign, and epithelial stippling on papillae indicates activity when you stain it with fluorescent. Clinical signs include limbal papillae also. It could be a small area or degree or 360-degree. When they're confluent and gelatinous, it's called pseudogerotoxin. Onotrantar spots, often a pathognomic feature of VKC, is also basically limbal papillae with eosinophils along with least committed limbal cells. And you often have perilimbal pigmentation, which actually has been documented by my alma mater, Shankar Netralaya, first in 2005. Corneal involvement also can be documented by PEs or punctal erosions, related cause epidermopathy, and then Shields ulcer. So management of allergic conjunctivitis. So we have the medical management, the surgical desensitization, which is part of the medical, but also very rarely done. So I've labeled it separately. You also have non-pharmacological treatment. You need to counsel the parents and the patient. You have to ask for environmental changes. Often change of address is required if it's too severe. Preventive glasses have to be given, avoid exposure, cold compresses, avoid rubbing, and no window seats is something that I recommend to most of the patients who come to me with this particular disease. Medical management include topical second generation antihistamine. We have mast cell stabilizers, which are also there. Mast cell stabilizers often take a longer time to get in, so they are used more often prophylactically. Like before you know it's going to happen, you start mast cell stabilizer. Nowadays, dual-acting agents like ketotifen, olopatadine, alkafetine, levetiracetam, which are basically mast cell stabilizers along with antihistamines, are available over the counter, and these are generally the ones which are used nowadays. You also all have topical vasoconstrictors. You have topical corticosteroids. More stronger corticosteroids like dexamethasone, prednisolone are used in more severe diseases, severe form of the disease. And we have the T cell inhibitor drugs like cyclosporine, tacrolimus, which are very good with maintenance therapy. The systemic medical medication that can be used are antihistamines orally, oral steroids, which are used in severe cases, or when systemic cyclosporine and tacrolimus, which are used when there is a rhinitis involved. Omalizumab is something new, which will be used when IgE levels have been documented to be high in these patients. In VKC, the treatment is very individualized because every VKC is staged differently, and the case requires variable prescription. So severe forms should be screened for complications, and complications should also be treated. T cell inhibitors, cyclosporine, tacrolimus help in great maintenance therapy and often used. So this is how we grade VKC generally. We can grade it as mild, moderate, severe, and then blinding. A simple practical playbook that I follow is when mild cases, I use either short-term NSAIDs, weak steroids, antihistamines, behavioral changes. As it gets more serious, we step up our treatment. Like we use topical immunomodulators, we use low-dose steroids, sometimes oral steroids as well in severe cases. Later also require some subtarsal injections and surgical treatment in the blinding diseases or pre-blinding diseases. So various ways that this happens in VKC. Surgical treatment, we have to treat for papillae. You can give subtarsal steroid. You can do cryotherapy. You can excise the papillae. You can also excise and put an AMT there, depending on how severe it is and what you need to do next. So these are various severities that you can get papillae with. So you have to be very careful and treat them before they cause more harm. And these are various degrees of shield ulcer that you can also do. Immunotherapy and desensitization, it's whenever you know there's a clearly defined hypersensitivity to a particular allergen, that's when you do desensitization. and it's quite been documented quite successfully. Research advances and future perspective. These are various, this is just a figure I like to show that shows various different points that you can have a new drug which can cause a change in the cycle. So currently what we are talking about is diagnostic biomarkers, which is need of the hour. If you have one biomarker that can pick up the allergen, pick up the molecule that's really high there, and we can treat it. The microfilm drug delivery system, which has been spoken by Liu et al. And has shown good results, which we are looking forward to. Newer targets of treatment like cell wall components, eosinophils, mesenchymal cells, mast cells, and thrombospodin 1. So a lot of reading material that I can recommend, which is lately come up in 2022-23 that we can talk about. Thank you so much for your patient listening. I hope I was able to bring up new points.
That was really excellent. Yeah, Dr. Aditya, very, very nicely covered. I think that was a beautiful presentation. Dr. Shubhangi ma'am.
Aditya, thanks for covering most of the topics. I would like to know from you how frequently do you use tacrolimus or calcineurin inhibitors in your cases of pediatric? What age group you start using these drugs and how frequently you use?
I'm quite liberal with it now with older children and young adults. So as a maintenance therapy, I'm using tacrolimus and cyclosporine quite frequently now, along with when I start them with oral steroids, topical steroids, and then I use this as maintenance therapy.
Yeah, because I found them very useful, and it goes a long way in reducing the dose of steroids, covers the dry eye also. After the age of 4 or 5, we can use them easily in the children to control
and they're quite acceptable by the patient as well.
Yes.
Tacrolimus especially had that question about it, but it's quite acceptable. I've seen it's quite acceptable.
We have to tell them exactly how to use and how little to use. So once you tell them properly, if they use it that way, then it's not too bad.
For the benefit of our viewers, ma'am, can you please tell us this important tip?
What I tell me? You asking me now?
Means
Aditya.
Yes,
Aditya can tell.
Aditya. Yeah, ma'am. Yeah.
So, ma'am, the quantity of the ointment that we need to put, we give it twice a day. So we generally say less than half a rice grain, 1/4 of a rice grain. That amount is enough, and then blink a couple of times so it spreads. Then close the eyes for about 5-10 minutes. And then monitor for any allergic reactions to the particular medicines. These are the only parts. And also often with cyclosporine and tacrolimus, if you give them a low weak surface steroid to start with, they accept it much better.
But they usually complain of burning, stinging.
Yes. So we start with...
Yeah, I even tell them to apply it slightly outside the lid margin also, at the lid margin. So that is also enough. That should also be added.
And do you all follow a flow chart as to, along with the steroids, first tacrolimus or first cyclosporin? If it doesn't work, then the second one, or you add both of them together?
One at a time, generally. So we start with surface steroids, then we bring in the tacrolimus or a cyclosporin, not both together generally. One is generally enough to have the maintenance therapy going for a longer time.
So when you start the other one, the first one is stopped and then you start the other one, right?
Yes, ma'am. Sometimes the surface steroids overlap. Yeah, sometimes the surface steroids overlap.
So how long you are going to take? How long will it take to decide that now we need to switch over to the other one? Say from tacrolimus to cyclosporin. How much time you would like to give for therapy? 6 months, 3 months?
Yes, 3 months or so, sir. If tacrolimus works, then I don't think you need to switch at all. But if tacrolimus doesn't work, then we try to switch to cyclosporin, which has been there for a while and more acceptable.
That's true. Yeah.
Yes.
The cyclosporin which is available, I mean, one is in the vial form and one is now available
preservative
without
free.
the preservative. So you recommend the preservative free.
Preservative free is more useful, like in the sense that the child accepts it better, though financially it's more expensive. So I think I take a call based on the child and the patient, how tolerable they are, or what's going to happen. But I always start a low dose surface steroid before. Otherwise, they reject it very fast because for stinging and everything else happens more often. Even for inflammatory dry eyes, it's the same story. You have to first start with the surface steroid.
It can
Thank
be
you.
combined with the lubricants also.
Yes.
Make
yes,
it more
definitely.
tolerant.
And
I think it is important for parents to tell about the adverse effects and steroid abuse.
Steroid abuse. Yes.
As
absolutely. Not to-
doctors, we should always
Absolutely.
specify the taper as well as the duration, because I have seen children going blind not because of allergies, but
Because of
because
the
of
medication.
steroid
complication
abuse.
of
So a lot
treatment.
of times this, when don't write prescriptions, open-ended prescriptions where duration is not mentioned.
Yes, ma'am.
I think you should take a minute to talk to the parents about possible steroid effects, because they give very quick relief, and that's why the tendency for abuse is more.
Yeah, so specific instruction not to self-treat and avoid rubbing of eyes.
Yes, ma'am.
Yes.
Yeah, so I think shall we move on for want of time to the next talk? We'll have, are we going right or straight down? Roshni,
Next is Henav. Dr. Henav.
Okay. Would like to invite Dr. Henna Dillon. She'll be speaking to us. Is anything wrong with my child's eye?
And we'll maintain 6 minutes so that we have adequate time for discussion and
Yes.
highlight all the
7
speakers.
minutes, I believe, 7 minutes. Sunil,
7 minutes,
if you
okay.
can just help us and give a hint at 30 seconds when it is left. Sunil, request.
Sunil ji, 6
Yes,
minutes 30 seconds पे
Minutes.
आपको timer देना है. Please
Yeah,
time.
7 minutes is the talk, right?
Yeah.
7
Yeah. Otherwise, it will go on till 11 p.m., you know. So we
Yeah.
have to have some time management also.
Thank
Yeah.
you.
Thank you, Sunil. Yeah.
Good evening, everybody. I hope my slides are visible.
Yes, now.
Okay.
Yeah.
I'm going to talk about this topic that was given to me. Is anything wrong with my child's eye? So my presentation, I'm going to answer a few questions. Basically, the questions that a parent asks when they come to our OPD. A lot of parents, young parents, new parents, they are very apprehensive about with the child's visual behavior, and they come with a lot of apprehension. So I'm going to answer those questions. The first question that I often observe is, my child is not seeing my face. So what can be the probable causes for it? It can be either delayed visual maturation, which may be isolated. It may be associated with systemic or an ocular disease. A very common association these days is cerebral visual impairment. So what do we do with such children? We take a detailed birth history regarding birth asphyxia, neonatal hypoglycemia, or any cerebral insult that has taken place during the first couple of hours of life or the first few days, including histories such as did the cry child immediately at birth? Was there an ICU admission? Was there a history of oxygenation? If the child has an associated developmental anomaly such as microcephaly, hydrocephalus, we also go ahead and do a comprehensive anterior segment and a posterior segment evaluation, especially an optic nerve evaluation, wherein we very commonly see temporal pallor, or we may see optic atrophy. We do order for MRI brain in orbit, where we may see periventricular leukomalacia, demyelination changes, and we may also go in for electrophysiological tests, wherein we do an electroretinogram or visual evoked potentials to look for the retinal function and the optic nerve function. So here are certain pictures. This is a picture of an MRI showing periventricular leukomalacia, or in the other optic nerve picture, we can see that there is marked temporal pallor of the optic nerve, or there is optic nerve hypoplasia. A corresponding VEP of the same eye showing nearly flat VEP responses. There is a marked delay in the P100, the latency, and reduced amplitudes. Autofluorescence pictures of the retina can, in a near normal looking retina, can also give us a clue if there is an associated retinal anomaly. A very common another very common complaint of the parents is, my child is poking his eyes. What do I do? So child poking, and this parents often confuse with allergy or with itching or with an infection, but this is actually a sign of extremely poor vision. It is because of the scintillating effect. It is release of phosphines known as an ocular digital sign, and very commonly seen in children who have very poor vision. So this is a video that is showing a child who has ocular digital sign. They do not respond to any auditory stimuli. They keep poking their eyes. In such cases, it's very important to take family history of consanguinity or birth history of prematurity. Again, an ICU stay, oxygenation that may be related to retinopathy of prematurity and its sequelae. a flash value, a hypermetropic flash value on cycloplegic refraction gives us an indication that there may be an associated Leber's congenital amaurosis or a retinal dystrophy. Paradoxical pupils on a pupillary response, wherein the pupils dilate on shining light, can also be seen. A fundus evaluation should be done as to look for RP mottling, which may not be sometimes visible on a clinical fundus evaluation, wherein again a fundus photography or an ultra wide field photography these days, optos with autofluorescence, is very helpful. Again, electrophysiological testing is a good option for such children. Here again, we see that in the child that we see above here, we did an ERG test, which is showing reduced responses to dark adapted and light adapted responses. This was a child with a cone dystrophy. We can see that the fundus picture is near normal here. And when we do an autofluorescence picture, we do CRP mottling and changes. And then the OCT in the center is of a different patient showing foveal thinning. A lot of times, another very common complaint is that my child has misaligned eyes. So we need to ask certain leading questions, such as, does the child have inward deviation, outward deviation? Is the deviation constant? Is it intermittent? Is it for distance? Is it for near? Are there any associated signs, like is the child blinking their eyes in the sunlight? Is he squeezing his eyes, or things like that? So in the pictures that we see above, yes, there is a true deviation. In the picture that we see below, there is a pseudo strabismus. A lot of facial features such as wide angle kappa or wide nasal bridge, epicanthal folds can lead to a pseudo strabismus. Vision needs to be checked. In these children, we need to perform a thorough motor and sensory evaluation, look for the fixation behavior. We need to check for stereopsis. We need to look for the ocular motility to look whether the strabismus is comitant, incomitant. Cycloplegic refraction is very, very necessary to rule out any accommodative exotropias or undetected myopias or astigmatism that can lead to intermittent divergent squints. Detailed anterior and posterior segment evaluation is a must, because sometimes in children with prematurity, they may have macular drag leading to pseudo exotropias. So another very overlapping question is that a child is shaking his eyeballs. Sometimes it may not be very visible. So we may make a video like this where we see fluctuating red reflex as we see in this child. The most common differentials for such a thing is either the child has an infantile nystagmus syndrome, which is associated with otherwise a normal anatomical development, or there may be a visual deprivation nystagmus, or nystagmus secondary to developmental anomalies of the eye, like ocular albinism or foveal hypoplasia. Such children may often present with abnormal head posture. We should notice that as soon as the child walks into our OPD, or when the child is reading binocularly the Stenlen's visual chart. This may be for the nystagmus null to get maximum visual acuity and clarity. We need to check for visual axis alignment and the clarity of the visual axis. If there is any opacification, a detailed anterior and posterior segment evaluation needs to be done to rule out any congenital anomalies such as colobomas or congenital cataracts or other retinal problems. Again, electrophysiological testing is very, very important in such children. In otherwise normal looking eyes, we may detect some rod cone dystrophies.
30 seconds left, doctor.
Macularosities, we can pick up foveal hypoplasias. My child has a white and a black dot in the eyes, very, very common childhood cataracts, congenital corneal opacities, limbal dermoids, retinopathy of prematurity, Coates disease, and extremely important retinoblastoma. We need to do a detailed, thorough workup in these children. We need fundus pictures. We need blood workup in such children as well. Retinoblastoma cases, we do need an MRI to rule out pineoblastoma. My child is frequently blinking and has watery eyes. Again, need to ask some leading questions here. We need to check for vision, look for any uncorrected refractive errors. We need to look for any signs of allergy, or we need to check for the RO+ and look for any NLD obstruction. Child is tilting his head, again, is a lot of nystagmus or ptosis, or look for ocular motility and look for fundus torsion as well. Cases of superior oblique palsy may present in such a way. So the clinical pearls that I have is that spend some time observing the child as soon as they enter the clinic, spend time taking a detailed history, do not dismiss a parent's observation without a thorough examination, plan an examination under anesthesia if the investigations are needed for these infants, and do not hesitate to call the child for a short follow-up to confirm the clinical findings. Thank you.
Thank you, Dr. Hino, for a very interesting talk. Just one thing I wanted to say, we must look for prematurity and low birth weight. I think the two important things we quite often forget, and we go on examining and doing all kinds of things without going into this aspect. And one thing more about PVL, I have seen children with PVL which get diagnosed as glaucoma and they get treated, they are put on treatment because the cups look really large, about 0.8. I had a child recently and nobody advises an MRI or even thinks of prematurity or PVL, and they are put on glaucoma treatment, timolol and all that, and they go on using for years. So in PVL, this may look quite glaucomatous, and if it happens early in this in fetal life, then there is optic nerve hypoplasia, and if it happens later, then there are large cups. So I think this we need to keep in mind and rule out PVL before we put them, diagnose them as glaucoma. I think that caution is there.
Yes, I agree with you, sir.
Yeah.
Thank you, Dr. Hina, for a wonderful presentation. Actually, regarding cerebral visual impairment, kids who, doing an MRI does have a very prognostic value. I mean, if you get to see MRI changes like hypoxic changes in the occipital lobe or in the corpus callosum, they usually indicate that the prognosis or the visual outcome may not be as good. So, MRI plays a significant role in this.
And most of the cases have a normal appearing eye and normal appearing fundus. And before they come to you, they've already visited a few doctors and they fail to know what is wrong with the child's vision. So MRI tells you exactly the problem, and it's enough to convince the parents also that there is a problem with the child's vision.
Just a short question to create more awareness among the general public as to for the early diagnosis of such things, because many people may still continue to wait because they may think that maybe the child is having delayed milestones or whatever. So what can we do as ophthalmologists to improve awareness, and what specific instruction we can give to the parents or to the pediatricians how to pick it up early?
Yes.
One important thing is that, sorry, you go ahead, Anna.
Ma'am, please go ahead, ma'am.
No. So as Dr. Pandey said, first you have to, I think, identify the high-risk children. So high-risk children who are likely to have these problems are premature, those who have had a very stormy perinatal period, who are low birth weight, who have had ischemic episodes, or who have had hypoxic episodes more than ischemia, hypoxic or neonatal septicemia. So these children are high-risk children who are likely to have cortical visual or cerebral visual impairment, as it is called. So if you get, and these are the children who are most likely to have eye problems also, of all sorts, whatever she was saying. So I think first we should increase the awareness that these children need early evaluation, even if they are looking normal. Second, if they come to you, at least do refraction, look for amblyopia, give appropriate glasses, and early intervention in terms of vision therapy and all, because the earlier you intervene, the better it is. And intervention can be as simple as a pair of glasses, a good refraction and pair of glasses. If there is any strabismus or if you think there is amblyopia, give amblyopia therapy. For that, we don't need any specialized equipment or testing. An MRI, as Rishi was saying, MRI almost always clinches the diagnosis. So yes, these children need some amount of rehabilitative services more than ophthalmology services, but as doctors and as pediatric ophthalmology, we should take a coordinating role in directing parents to the services. There are government centers which are now called DICE, or District Early Intervention Centers. So even the poorer, they are all equipped with rehabilitation person as well as an optometrist for vision therapy. So I think it's good as doctors, if we don't want to take the responsibility for really treating this child who needs other services, you should definitely guide them appropriately.
Absolutely. Thank you.
Yeah. I think we
Nobody
need to
stops
integrate with
thinking
pediatricians. Pediatricians are very important in this aspect. They don't send children to us, and by the time they send them over, it's quite late. So I think that's one thing we need to have
Right.
better rapport with pediatricians, and every child should have a refraction by at least, I think, latest by 3 years, preferably by 1 year. Those who have a problem, those who don't have a problem, they should also have a refraction done, I think, at least by 3 years. What is happening? They go for amblyopia and a lot of things, and they are never seen. So I think that's major public health issue with us.
But as anybody, any ophthalmologist can take care of amblyopia and give appropriate glasses. I think we all should do that.
Yeah, yeah.
Refraction
reach
So much,
classes, and yeah, that you don't need any special training in pediatric ophthalmology.
They don't reach you, what I'm saying is they don't reach you. By the time they
Yeah.
reach, they are 8 years, 10 years, and a lot of things have been lost.
Sometimes they reach ophthalmologists and still nothing.
Yes, that is also there.
Sometimes they are referred to pediatric ophthalmology. There is unnecessary delay in that whole process. I think everybody should take charge of these children. Yes, this is
Refer
what.
to an ophthalmologist. Refer to an ophthalmologist, not a pediatric
Ophthalmologist,
ophthalmologist. No, there is a
I don't
difference.
think-
I think this is the
reason.
important message that we will send through this
Yeah,
webinar.
that's the precise reason why we are having
Yes.
webinar for this.
So do
I
not-
think we will continue with, because
Yeah.
now we come to refraction, the next topic by Dr. Roshni Desai is on the same, how to do a refraction and prescribe glasses for children. So I'll request Dr. Roshni to share her presentation.
Very good evening. Respected organizers, my mentors and friends, and some juniors. Thank you so much for giving me this important topic in pediatric ophthalmology. So I'm going to share some tips and tricks in prescribing glasses in children. And to start my talk, we have established the role of early refractive error correction in children with lifelong benefits to the child. So just for general ophthalmologists, 30% of the OPD is pediatric. So how is refraction in children different from adults? So let's just go through the ABCD of the same. Kids often accommodate much more than adults, and hence problems such as uncorrected hypermetropia. And nowadays we have documented the role of accommodation in progressive myopia need to be taken care of. How is it different if it's a baby? Well, we might not have any complaints. We might not have any vision record. We might sometimes not have cooperation. And there has to be a complete dependence on the parent's history, our examination of central steady maintained fixation, retinoscopy. We have to keep in mind the different visual demand in growing child with a plastic cortex who is more vulnerable to amblyopia, strabismus, and loss of binocularity. Often parents do not understand the importance of these glasses or treatment modality like patching. And so I often tell them how important it is for the child to go to school. Like the child will cry, but you will still send. And that's how you have to enforce that if the child doesn't want to wear glasses, you still have to make them wear because you have to believe it's important for them. Cycloplegia. So the routine dilatation in adults is Tropica Plus. Unfortunately, that doesn't reveal the latent hypermetropia or mask the pseudomyopia. Hence, we use cycloplegic drops like hometropin or cyclopentolate. You can use your choice of medicine. Traditionally, we have been trained with CTC. That's a 5 minutes gap between 0.5% cyclopentolate, Tropica Plus, and again cyclopentolate, and refract 40 minutes after the first drop of cyclopentolate. Now, how do we translate our retinoscopy? How does the angle of deviation affect the final glass prescription? You will be only able to define that if you have done a cover test before doing the retinoscopy. So in presence of esophoria or esotropia, we need to give full hyperopic correction or sometimes bifocals. And in presence of exophoria or exotropia, the minutest of myopia or astigmatism has to be corrected, and rarely we have to undercorrect hyperopia also. So some tips for refracting the child. Ask the parents to make the child comfortable in their lap. Never, ever, the doctor who's going to, or the optometrist who's going to do the retinoscopy should put drops in the child, because that person immediately becomes the child's worst enemy. And hence, please outsource that job. Take the child in a dark room with a bright target to fix on. And in presence of squint or nystagmus, always cover the eye to avoid an off-axis reading. I avoid doing refraction under anesthesia because of errors in cylindrical numbers. So when we have the final retinoscopy with us, how do we convert it into a final glass prescription? Just ask yourself 3 simple questions. Is this refractive error an amblyogenic one? Is it visually significant? Or is it going to affect the strabismus? Also, look at the child's ability to accommodate. If it is a pseudophakic or aphakic patient, also if it is a child who has pseudomyopia or a child with high AC by A ratio, type of an esotropia. See the visual needs of the child. For minor refractive errors, if the child is still in the preschool age group, you can just give the parents a slight hint of a presence of a refractive error which might need spectacles in some later age. So how do you know what is amblyogenic? When visual acuity recording is not available, what is defined as amblyogenic is standardized by the table given by the American Academy of Ophthalmology. Just a brief of this table is, as the child age increases, the threshold for prescribing the refractive error reduces. And the threshold is even lower in cases of anisometropia and in presence of strabismus. So if a 2 or 3-year-old walks into your clinic, what will you give glasses for? So myopia more than 3 diopter has to be corrected once the child starts walking. So if the child has already started walking, we have to give them myopia glasses. More than 6 diopter glasses for myopia has to be always corrected, irrespective of the child's mobility status. More than 4.5 diopter hyperopia should be corrected if there is no manifest esotropia, and it's 1.5 diopter if it in the presence of an esotropia or a phoria. And more than 1.5 or 2 diopters astigmatism should always be corrected. If the child appreciates the difference with spectacles, they will wear it, because that's the common question from parents. My child will not wear glasses. But you tell them this. If you see the child wearing the glasses continuously, being happier, being more active, then the child is appreciating the difference. So they will wear glasses. Special situations in which we have to give bifocal glasses is in cases of high AC by ratio or accommodative insufficiency. There is something called dynamic retinoscopy, which we do now with the current studies of myopia. And initially, we used to do this in kids with developmental disorders, where you pick up accommodative anomalies. High suspicion is, as we have already discussed in the previous talks, that there should always be a high level of suspicion when a syndromic child walks into your clinic. And what is the spectrum of refractive error in these children? So hyperopia is usually associated with LCA, early onset RP, Down syndrome, non-ophthalmos, whereas myopia is more rampant in Marfan's homocystinuria, albinism, Ehlers-Danlos, Sticklers, retinitis pigmentosa, and most importantly, prematurity. We have to suspect astigmatism and refract every child with a mass like a capillary hemangioma or Sturge-Weber and ptosis. So on
30 seconds, doctor.
On follow-up, always modify the prescription and further treatment depending upon the severity of amblyopia and the angle of deviation. I always over-refract on top of my glasses to notice any change. I do the minus 0.5 diopter test to see if the myopia has increased or hyperopia has reduced. Always check for loose-fitting glasses, because in absence of perfect centration, the complete benefit is not taken care of. Please make note of these marks, because every child now at 18 wants to get LASIK done. And if you leave them with such horrible marks on their nose, you're not doing them much good. So tell the parents to buy cheaper glasses and change them every 6 months. Look for scratches, because that itself can reduce the visual acuity by 1 to 2 lines. In special situations, we prescribe polycarbonate glasses in one-eyed and amblyopic children, UV protection in cases of maculopathy or on atropine penalization, and tinted or photochromatic glasses in suspected aniridia, albinism, and cone dystrophies. So art of dispensing spectacles is good spectacle fit. A light frame should not hurt nose or ears. It should cover the entire height and width of the palpebral fissure, and a restrainer should be passing behind the occiput. There are special glasses now, flexible ones available for craniofacial dystosis. I always give a snapshot of a Lia symbol chart, and I make sure that the child at least does some matching in the next visit to get a rough idea of the visual acuity. And in very special situations, we can give them an option of contact lenses. Take home is, please attempt retinoscopy in every child and try to translate and give it a meaning. Thank you.
Can you stop sharing, Roshni? The
Yes.
screen? Yeah. Very well covered, the talk. And every one of us has come across cases where we unearth large amount of hypermetropia, and the parents say that there's no problem with the vision of my child. He can see smallest of things. So I feel, apart from other things, convincing the parents that their child needs glasses is of utmost importance. And I'm happy that Roshni has covered most of the technical points while doing the pediatric refraction. Thanks.
Thanks. Yeah, I think one thing is important. We should keep in mind that children who have strabismus and children who don't have strabismus, those the prescription is going to be accordingly monitored and tailored. The criteria would be different than those who have squint, like an ESO deviation, and those who don't have. That is, I think, important to keep in mind. And age, something which is happening at the age of 1 year may not apply to the age of 3 years and henceforth. So I think that is also very important consideration. We are all born hypermetropes. So part of hypermetropia is going to be lost by ametropization. So that process is physiological. That has to be, I think, kept in mind.
Thank you. Thank you, Dr. Roshni. So we can move to the next talk, that is by Dr. Sovita. Now we have done with the refraction and we have prescribed glasses. Now let us see what happens if a child with squint enters into your OPD. So she will guide us with the further management of this. Dr. Sovita, please share your presentation. You can unmute yourself.
I'm not able to share my presentation.
Doctor, you've got your presentation open?
Yeah.
Come back to
Yes,
the
it's
Zoom
a-
window. There is a green button, bottom 6 o'clock.
Yeah.
Click on it.
Yes.
A pop-up comes, the blue button, which says share.
Share screen.
Hanji.
No, but on my desktop it shows me an exclamation mark.
Are you on a Mac?
Yeah.
You will have to go to System Preferences and give Zoom permission. Just go to System Preferences, Security and Privacy, Screen Recording, and then you will have to tick Zoom.
Fine, I'll do it.
System Preferences, Security and Privacy, Screen
Yeah.
Recording, and then click tick Zoom.
No, after privacy and security.
Screen Recording. It should be below. The option should be there on the left-hand side below. Screen Recording in Privacy and Security.
Can we have the next talk so that
Yes,
Sovita
I think
keep
yes.
the things ready? Sovita?
I'm ready, ma'am. Mine is done
Ready?
now.
Okay.
Yeah, ma'am. Thank you. So good evening, everybody. Sorry for the glitch. And thank you, team, for giving me this opportunity to discuss on squint detected, what to do next. Hope my slides are visible.
Doctor, please go on.
It's visible?
Yes, Doctor, clear, absolutely. Please go and continue.
Thank you. So squint detected, what to do next? The first step is not to panic, and we have to go stepwise to analyze what is the type of squint and its etiology behind it, to measure the deviation, assess the binocular sensory status, and plan the next treatment approach. Now, to go a stepwise approach, for any case of squint, as discussed before, giving glasses is essential, but before that, an age-based vision assessment has to be done for every child, and an optimal cycloplegic refraction has to be done. Based on the criteria, glasses has to be prescribed And then we have to evaluate a case of squint. Now, to make things easy, I've made up this small mnemonic for all of us, which stands as heads up, where we first begin with redo the history a little for every squint case, do the extraocular motility, A for associated features and abnormal head posture, D for measurement of the deviation, the sensory workup, and U is unique tests, which is again case-based, and photos. Do not forget to ask for old photos or take new photos. Now in history, if there is a squint case, one has to ask what is the age of onset, the birth history, any abnormal developmental milestones. Did the squint manifest before a history, after a history of fever, trauma, convulsions? Is it seen all the times or sometimes? Any associated diurnal changes? Is squinting more when looking at distance or near? And was there any previous treatment done, like glasses, prism, surgery? And was there any improvement with it? Apart from this, as we begin, we should ask for any history of headache, diplopia, blurring of vision, etc. Then we come on to the motility evaluation. Motility should be always started with versions where we compare both of the eyes, any deficit is there or not. And then ductions, which means closing one eye, which will help us to distinguish whether it is a paralytic and restrictive. Now, there are no set limits for certain motility analysis like depression and elevation, but there are set criteria set to say what is complete abduction and what is complete adduction. For abduction, if the lateral limbus touches the lateral canthus, then it is a complete abduction. Whereas if the medial 1/3 of the medial limbus touches the punctum or crosses it, then adduction is full. So as we see in these photographs, here we see in the left gaze, the abduction is full in the left eye, whereas in the right eye, as we see in the right gaze, the right eye doesn't move out, saying that there is limitation of abduction. Similarly, in the second picture, we see in the left eye, towards the right gaze as the child is moving, then there is limitation of adduction. That means the medial limbus not crossing the punctum. But in the other picture, as we see, there is no landmark specific set for elevation and depression. We have to compare with the scleral show of the other eyes. We see the right eye doesn't go up in primary gaze, in levo up gaze, and in dextro up gaze. So therefore, there is limitation of elevation in this person. The next is obliques overaction, underaction. Now, obliques overaction and underaction, if the primary action of the inferior oblique overaction in adduction gaze is to take the eye up, so we have to analyze the action of inferior oblique and superior oblique in adduction gaze, considering an imaginary line passing between both the eyes, and then we ask the child to adduct, look at the adducted eye, how is it going? If it is going parallel, then there is no overaction. However, if it takes an up movement, like an upshoot or downshoot, and it is graded, considering it to be a 90 degrees, whether it is 1+, 2+, 3+, 4+, which we see in this direction. Similar, it is for superior oblique overaction. It is overaction in depression, in adduction. And if it is not going up or going down as it is supposed to be, then it is underaction. Now come to A. In A, we look for associated features, which has already been discussed, whether there is any presence of broad nasal bridge to rule out any pseudostrabismus, whether there is any positive angle kappa to rule out any pseudostrabismus, or there are some external facial anomalies like hypertelorism, if there is any facial asymmetry in certain cases, if there is any pseudotosis in cases of monocular elevation deficit or in cases of CCDS, and if there is narrowing of palpebral feature changes. So overall, we should look at the face as a whole to see if there is any abnormality to pick up, which may be associated with different syndromes or different etiologies. Coming on to next, A is abnormal head posture, which can be either a right face turn, a left face turn, a chin up, a chin down, or a head tilt and left head tilt or a right head tilt. Now, as we ask the child to look give him an accommodative target and ask him to look towards the chart, reading towards finer print, the child who will have a face turn to enhance his binocular vision to avoid diplopia will take, or an adult will take a face turn or a head posture, which is a compensatory head posture. Now, measurement of this head posture can be done using a goniometer, and it is simple scale and protractor combination, which will tell us how much is the degree of abnormal head posture. Based on that, further measurements, further management has to be done. Now, coming on to the motor thing, which is the deviation, it begins with a Hirschberg or corneal reflex test, where we throw a light at the glabella and ask the patient to look into that light. What we analyze is the first Purkinje image, and based on its centration as seen in this figure, we classify if it is a nasal reflex, it is exotropia, and a temporal reflex, if it is esotropia, hypertropia, and hypotropia. Now we go on to cover test to see the type of squint measurements quantifying. Before that, we have to rule out pseudo squint, eliminating all our facial features like broad nasal bridge, check fixation to check whether it is a central fixation or eccentric fixation, where Hirschberg is a binocular reflex assessment. Eccentric fixation is a uniocular assessment where we have to ask the patient to close one eye and then throw the torch, then see the reflex, whether it is center or away from the center. Now, if the motility is not there, one cannot do a cover test. So these were the few prerequisites for cover test. In case a cover test cannot be done in the absence of this, we go on to do a Krimsky's or a modified Krimsky's, where prisms are placed over the Krimsky's over the affected eye, and we see the centration of the reflex as the patient tries to take fixation. In cases where movement is not possible, then we have to do Krimsky. But because the centration is not so well appreciated through those thick prisms, then it is modified Krimsky's, where the prism is kept over the good eye, and we see the reflex in the refixation movement of the bad eye. Now, an alternate cover test has to be done in all the cases, then alternate prism cover test to see the measurement. The base is away from the deviation, and we progressively increase the strength till we see the reversal. Measurement has to be done in all 6 cardinal gazes with prisms to be held properly. Plastic prisms generally we use are used in the frontal plane, and then we mention over which eye we place the prism. It has to be done with left face turn to see in the right gaze, in right face turn for the left gaze, up and chin down position along with head tilts. To check for up and down, we have to see whether there was any pattern, which is A or V pattern. On these A or V pattern is if A pattern is difference between up and down gaze of more than 10 pt, V pattern is more than 15 pt between up and down gaze. Sensory is a subjective test basing on the fusional status, which has to be done both for distance and near. We can do a Worth-Fodor test to analyze what is the sensory status, and stereopsis. Mind us that these all our stereopsis charts are for near. In rare cases, we have stereopsis charts for distance. Then comes the unique test, which are Hess charting and a diplopia if patients have diplopia. Sometimes in cases of oblique overactions, we need to assess the torsion, and we can do that by taking a fundus photos or by doing a DMR. Other tests which we see here are the force duction test or force generation test to distinguish whether it is a paralytic or a restrictive entity, which can be done both in an OPD setup as well as intraoperatively. However, in all this, in OPD, it has to be done under topical anesthesia and adequate explanation to the patient. And then CT scan, MRI are also required in certain cases, like in thyroid or in strabismus fixes, to look for the placement of the muscles, the hypertrophy of the muscles, any abnormal band in cases where there will be an inophthalmos or synkinetic movements, and in congenital cranial disinnervation syndrome to look for an abnormality in the orbit. Now remember, photos was our last thing. So when we do photos, we should always ask for old photos to see in cases of acquired squint. Like in these children, that the mother came with a complaint of head tilt, but the similar head tilt was not noted few months before. This is another child whom I had seen 3 days before. She was ortho, but now she has come back with an esotropia. This is a family of CF EOM who have head posture. The documentation of the abnormal head posture helps us to know what amount of correction is done apart from measurement of goniometer. Now to document, there is a 9-gaze app which helps us document in every gaze what we need, and with correct identity, which will help us store it for longer. So to summarize, once detected, evaluate squint following the mnemonic heads up, correct the refractive error, treat amblyopia patch, and then remeasure deviation and check sensory status as well. For smaller deviations, orthoptic exercises, prisms, and over minus glasses can be done meanwhile till you get consistent measurements. And if the longer deviations or larger ones or those who have constant squint would need a surgical management. Always discuss with parents what is the goal of the treatment and do the follow-up regularly so that we are helping them improve vision and enhance fusion. Thank you.
Thank you for a very nice presentation. I think one thing I just wanted to say that 3-step test and evaluation of torsion, fundus torsion at times can really help you, and we tend to overlook evaluation of torsion, especially if it is acquired condition, you have diplopia, and it doesn't look like that there isn't too much of ESO or EXO or hyper, and patient is quite in trouble. He is really trouble, and then you look at the torsion and you find that there is a fourth nerve palsy and there is an extorsion. At times it can even be bilateral. So always, if you are having a situation which is difficult looking, then always look for torsion in all these cases. I think that's an important thing. We tend to overlook that, so that's why I think it should be stressed.
And in vision assessment, always try to detect amblyopia. In children who are non-verbal, the behavior of the eye itself tells us the presence of amblyopia, which has to be corrected before we go ahead with the strabismus
Squint
correction.
management. Resistance to occlusion can be done in all those cases where we can.
Constant deviation in one eye are particular clues which tell us, even without recording the vision, that there is presence of amblyopia.
Especially for postgraduates, I mean, evaluating a case of strabismus becomes an important part, especially for the practical exams. So get into the fluency of doing a cover test, uncover test, and alternate prism cover test. Because if you are not good at it, the examiner will easily point it out, and I mean, that will be hampering your passing the exam. So be in the habit of doing the cover test or the alternate cover test routinely.
And those general ophthalmologists who are watching, if you don't feel comfortable, we are there. All of us. Let's do refer early.
So with this, I think we move to the next presentation. Important and hot topic right now, myopia and management of myopia progression. I request Dr. Stuti to share her presentation, please.
Thank you all for the opportunity to talk this morning. So myopia is a multifactorial condition with many genetic and environmental predispositions. The prevalence of this condition has been on the rise, especially since the pandemic, and the WHO estimates that about 50% of the world population will be myopic by the year 2050. An increase in myopic refractive error more than 0.5 factors per year is known as progression. Why are we talking about it? Is because myopia and high myopia can cause some irreversible pathological changes like glaucoma, retinal detachments, and myopic macular degeneration, which can cause irreversible visual loss and financial burden. Hence, by preventing or decreasing the progression of myopia, we aim at decreasing sight-threatening complications later on in life. Now, what can be done? First and foremost, we need a detailed history, especially about myopia in parents or running in families. The screen time and outdoor activity exposure today in today's generation is a must, and any syndromic association. It needs a complete ophthalmic evaluation, and a cycloplegic refraction in all cases is a must. Now, depending upon the case-to-case basis, we may decide upon axial length recording, binocular vision assessment, or a corneal topography. The treatment options include lifestyle changes, pharmacological options, and optical devices in the form of glasses or contact lenses. Now, increased screen time, decreased outdoor exposure, the competitive educational system, so much of pressure has contributed to an increase in myopia. And hence, we suggest at least 2 hours of outdoor exposure in sunlight, decreased screen time, use of bigger screens, adequate illumination, a proper working distance with frequent breaks. Studies have concluded that a hyperopic defocus relates to axial length elongation, and a myopic defocus prevents the same. Hence, glasses aim at reducing this hyperopic defocus, create a myopic defocus, and also deal with any accommodation lag or high AC by A ratio and esophorias, which may be associated with myopia. The options include spectacles. So we need to give single vision glasses to all children, and we never undercorrect a myope. But there are specialized glasses also now available for treating this myopia progression, or contact lenses. A few words about the DIMS glasses, which is the defocus incorporated multiple segments. These are custom-made plastic glasses. They have a central zone of 9 millimeters correction for a distance correction. They provide clear vision. This is surrounded by 33 millimeter area, which has 400 multiple defocus segments. Each of these segments, defocus segments, has a plus 3.5 diopter power. This segment creates a myopic defocus. Hence, these glasses will simultaneously introduce a myopic defocus as well as provide clear vision for all viewing distances. They are prescribed when myopia progression is noted, and the final glass prescription is always based on a subjective and cycloplegic refraction. Studies have shown that the daily wear of DIMS will slow down the myopia progression and axial length elongation as compared to the single vision lenses. Now a few words on the HAL, which is the highly aspherical lensless target. These glasses have a spherical front surface with about 11. Am I audible?
Yeah, of course.
Yes, audible.
Yeah. So these are the HAL glasses. This has a spherical front surface with 11 concentric rings. They are formed by aspherical lensless. The area of this lens without the lensless will correct the distance correction, and the geometry of these aspherical lensless create a volume of myopic defocus, which serves as a control for myopia. Now, spectacle lenses, the control studies have shown that HAL has a greater efficacy compared to SAL, which are the slightly aspherical lensless, or the SVL, which is the single vision lens glasses in myopia progression. A few words on bifocals and the progressive additional lenses of the PAL. It slows the myopia progression in children with near point esophoria by decreasing accommodative effort for near and minimizing the retinal blood, and this is correlated by the COMET study. Options for contact lens include the soft multifocal contact lens or orthokeratology. The soft multifocal contact lens has the same working principle as spectacles. So there are lenses with concentric rings of distinct zones with plus power, or they may have a gradient design with increasing plus power towards the periphery. Ortho K lenses are reverse geometry RGP lenses to be worn overnight to flatten the cornea. This causes central corneal thinning and mid-peripheral epithelial or stromal thickening. And this redistribution will temporarily correct the myopia the next day when we remove these contact lenses. Both of these have shown to reduce myopia progression as well as axial length elongation. Pharmacological options include atropine, pirenzepine, and 7-methylxanthine, of which low-dose atropine is the most commonly used agent with the strength 0.01% in the age group 4 to 16 years. The theory now is it upregulates certain anti-scleral elongating molecules like dopamine and downregulates certain scleral elongating molecules. The ATOM study, the LAMP study, the IATOM study have all concluded that atropine is effective in slowing myopia progression, and 0.01% atropine has minimal side effects compared to the other strengths. It causes least amount of pupil dilation and accommodative loss. There is a rebound phenomenon which is higher in higher strength of atropine. Now, for pre-myopia also, low concentration atropine prevents the progression of myopia in the pre-myope. And for higher strength atropine, recent meta-analysis has concluded that 0.05% is the most beneficial concentration, and the adverse effect, as mentioned earlier, will increase with increasing dose or increasing strength of atropine. So the takeaways are, we never undercorrect a myope. The anti-myopia therapy should be started when myopia progression is documented. Either we compare with the old glass prescription, or we can rely on the history of frequent change of glasses, increasing power of glasses. Parental education for constant use of glasses, lifestyle modification, and contact lens hygiene is a must for all our consultations. Low concentration atropine, 0.01%, is the most commonly used agent. High-risk groups may need early intervention with combination therapy, spectacles, and medication. This high-risk age group is those with younger age group, strong parental history of myopia, or a higher baseline refractive error at presentation. Evaluation of binocular vision status so that we can prescribe PALs or bifocals to take care of that, and a follow-up should be stringent. We are looking forward to the exact protocol of discontinuation to increase dosing regimen or concentrations, the safety profile in less than 4 years age group, a role in pediatric pseudophakias and ROP, more studies for pre-myopias or combination therapy with DIMS or Hall glasses and atropine. Thank you.
Thank you for a nice presentation. I think we have brought out our SPOCI and TOD guidelines on in myopia on prevention of onset and retardation of progression. And it is a very burning topic and like an epidemic. And we all need to create awareness about this. And of course, a lot of work has to be done. A lot of things are in gray area. And I think we need to work more on pre-myopia, because pre-myopia is one thing which we can detect early and prevent it from going into myopia. So I think that's one aspect which needs to be stressed more in this situation. And of course, drugs are cheaper. I mean, atropine is much cheaper than all those optical devices. So from public health view, I think 0.01% or whatever percentage of atropine drops is, I think, much more acceptable from economic point of view than the other modalities of treatment.
We must thank Pandey sir for all his efforts in bringing out those guidelines. I also just want to make one point is all these therapies are aimed at reducing the progression. Most often and not, we see that low-dose atropine prescribed at the first visit. So one has to emphasize that all these therapies are would reduce the progression and not reduce the myopia.
Yes, absolutely.
Thank you, Dr. Stuti, for a wonderful presentation. I think we'll move to the next presentation by Dr. Varda. She'll be speaking on Amblyopia. Please share your presentation, Dr. Varda.
My slides are visible.
Yes, visible, audible, both.
Yeah. Okay. So first of all, thank you AIOS, POSI and my mentors for giving me this opportunity. I'm going to talk about amblyopia diagnosis and management. So this is the overview of my talk. A quick case, a 5-year-old boy came to my OPD with accidentally noticed left eye decreased vision. On examination, his best corrected visual acuity was 6/6 N6 in the right eye and 6/24 N6 in the left eye. Cycloplegic refraction was done. It was minus 0.75 in the right eye and minus 3.5 with -1 cylinder at 90 degrees in the left eye. The rest examination was normal. So what is the diagnosis and what next? So the clear-cut diagnosis is anisometropic amblyopia. So amblyopia is a unilateral or bilateral decrease of visual acuity due to deprivation of pattern vision or abnormal binocular interaction in a structurally normal eye and intact visual pathways. Basically, there is a difference of 2 or more lines between normal and amblyopic eye, or the best corrected visual acuity less than 20/40 can be labeled as bilateral amblyopia. It can be strabismic, anisometropic, ametropic, stimulus deprivation, or a mixed type. There is other term called organic amblyopia, which means amblyopia is superimposed on an irreversible ocular abnormality, basically some retinal or optic nerve abnormalities. Another term is occlusion amblyopia, that is because of excessive therapeutic patching. It can be graded into mild, moderate, severe, depending upon the visual acuity of the worse eye. It can present with decreased best corrected visual acuity. There is a phenomena called crowding, but vision can be improved by giving single optotypes rather than giving lines or groups. Neutral density filter will not decrease the vision. In fact, they will improve the vision in the worse eye. There can be abnormal pursuit movements, reduced contrast sensitivity. Visual fields can be abnormal, specifically in exotropic amblyopia. There can be defective accommodation, and in very severe amblyopia, there can be relative afferent pupillary defect. We should examine these kids with best corrected visual acuity. If the patient is in verbal age group or in pre-verbal, we can look for fixation pattern, do complete cycloplegic refraction. Binocular vision should be tested. In children, we can do 4 prism base out or 10 prism base down test to know the fixation pattern. Cover uncover test should be done, and complete slit lamp and fundus examination is mandatory. We can manage these cases with 5 P's, that is, treat the principal cause, patching, penalization, passion, persistent, and a new P has been added, that is iPad therapy. The principle of management is to manage the primary amblyogenic condition, and second is increase neural stimulation of cortex by occlusion or penalization. So surgery is mandatory when there is obstruction to the visual axis by all these conditions. Optical correction should be given, detailedly discussed by Dr. Roshni in the previous talk. Occlusion therapy is still gold standard. We have to occlude the stronger eye. The duration of occlusion depends on severity of amblyopia, patient's age, visual acuity, compliance, physical, social, psychological status. So approximately 120 occlusion hours can improve 1 logmar of visual acuity. We can use different methods to occlude the eye. For infants specifically, it is best to be avoided before 4 months. We should only occlude 20% of the waking hours. Close follow-up is mandatory and watch for fixation switch. Amblyopia treatment study, everyone knows, done by Pedic group. They have different different protocols for severe, mild, moderate, and severe amblyopia. I'm not going in detail because of the time. What we should note in follow-up is documentation of cooperation, that is how much patient is doing occlusion and wearing spectacles, side effects of the therapy, visual acuity for distance as well as near, complete cycloplegic refraction every 6 monthly. We should note the binocular vision and also note the ocular alignment and control. Endpoint should be when the visual acuity is equal in both eyes or equal fixation in both eyes, or if there is no improvement after patching after doing 3 patching intervals with good compliance. We should keep patching if the patient is under 8 years of age, and always taper and stop patching. Penalization can be done optical or pharmacological way, that is 1% atropine can be used in weekends for penalization. Complications are noted like occlusion amblyopia, lack of compliance, skin irritation from patching, recurrent amblyopia, or failure to recognize the refractive or organic cause. So there are advances in technology, and we are finding out newer ways for managing amblyopia. A little bit about liquid crystal glasses, darkness therapy that we have to patch for 10 days. Acupuncture has been tried. Currently, we are doing binocular therapy, that is dichoptic training, because 2 eyes are better than 1. We have to dissociate 2 eyes by different special visual apparatus or by red-green goggles or decrease contrast. Here, we can give active vision therapy by using VR-based treatment. Here, the compliance is very good in young children. Anti-suppression can be given by synaptophore's gyroscope. Nowadays, VTS4 have been used. Binocs and revital vision are also very trendy. Perceptual learning describes the ability to improve performance on sensory task as a result of experience or practice. So this Gabor patch has been used to stimulate a particular area in lateral geniculate body, which improves the visual acuity. This is the basis of revital vision therapy. Newer things have been tried, that is repetitive transcranial magnetic stimulation, CAMS vision stimulation, pleoptics, and red filter treatment are coming up. So the secret of success of amblyopia treatment is early detection. If the treatment age is less than 3, the results are good. Presenting vision indicates the severity. We have to gain parents' confidence and children's cooperation for good compliance. Proper planning of the treatment and monitoring is mandatory. We need to guard regression by maintenance, and any strabismus needs to be realigned fully and timely. Recurrence of amblyopia is seen most of the in 21%. We can lose 2 lines of visual acuity after stopping the treatment. This happens mostly after 3 months of stopping the treatment, and 3 times if it
Dr.
hasn't
Time.
stopped suddenly. Yeah. So we should taper it slowly, and in less than 8 to 9 years of age, we should always taper and stop patching. So to summarize, amblyopia is extremely common, but it is preventable, treatable in early stages, and mass screening is the best way to detect amblyopia early. Thank you.
Thank you, Varda. That was a comprehensive presentation on amblyopia management. I think one thing I have to make clear, that if it is a severe amblyopia, patching is the way to go. And the recent treatments of binocs and all these things are only helpful in mild to moderate amblyopia.
Madam, in this binocs treatment, they say even in adulthood also it works. What has been your experience?
I have not used this Binox in the adults, but that's what I say, that it is if the amblyopia is anisometropic or the mild or moderate, it improves. In severe amblyopes, you have to resort to occlusion.
It's coming up in my talk. The same question will
Okay.
be answered in my saransh.
Okay, great.
I think the neurovision, I would like to ask about the Gabor patch that you have mentioned. So what is the minimum vision required to start the neurovision therapy for an amblyopic child?
At least 6/60.
You need 6/60, okay.
At least.
Because he has to do some task on the computer. He has to see the Gabor patches. So basically, Gabor patches is giving same stimulation, which is more stimulation than the normal stimulation that he is getting. So the patient should be able to at least see that, fix on the Gabor patch.
And what is the pathway actually working for regaining the vision with this Gabor patch?
So there are two theories that they are saying. One is that the Gabor patch is designed in such a way that so the normal question which we ask is that if you are closing, so in the Gabor patch also you are closing the good eye and you are telling the patient to use that Gabor patch to stimulate. Now the simple question is that if you are using a Gabor patch, you can use any video game. My point is that you cannot get more stimulation than what you will get out of, like your eye will be working 100%. So the answer is that in Gabor patch, the light is, the flanks and the light is in such a way that it stimulates more than what a normal stimulation will do. So, and the repetitive stimulations, that is what they call it as the perceptual vision therapy, that would improve the vision. That is the theory of Gabor patch stimulation.
And a lot of times the improvement is in the performing the tasks.
Yes.
In terms of contrast, in terms of speed, but how much of it translates? I'm talking more in terms of adults, which somebody was asking how
Yes.
Dr. Anka was asking whether it works in adults. So we all know that cortical plasticity, which we were taught that you cannot train the brain after some time. That is now no longer true. We all know that brain can be trained and taught at any time.
Things at any age.
Yeah, but does it? So, but best candidates who probably do well with all these adults I'm talking about are probably those who have anisometropic amblyopia.
Yes, very true.
And not really any other type of amblyopia.
No.
Let's be very
Even
clear.
Binox,
It is not magic bullet to treat any kind of amblyopia. In children also it works best in mild to moderate amblyopes, as Dr. Shubhangi was saying. It doesn't work for deprivation.
Not at all.
That is most difficult to treat.
It is most effective if you measure the improvement in terms of tasks which it is teaching or training rather than actual.
So most of the patients are patients who are failed patching therapy. I mean, most of our patients which we put on these therapies are patients who have already done patching and then they are not improving. So as a last resort, we sort of give them as an option, not really promising them that, this particular thing will be working as an option.
Right.
I think we are running
Let's
short
move
of time.
on to the next topic. Yeah.
I request Dr. Karthikeya. He will be sharing his presentation on ROP screening. So something which many of us are not practicing, but that will actually help us to guide the patient to a retina specialist. So Dr. Karthikeya, please.
Thank you, Dr. Rishikesh. Thank you, Dr. Prashant and entire ARC team for having me here. So I'll be giving this talk on retinopathy or prematurity screening. Is my screen visible?
Yes.
Yeah.
Please.
So as it is Pediatric Ophthalmology for All, I'll not be going into details of ROP treatment and all those things. So ROP is a major cause of avoidable blindness in children. NPCB says that there are almost every 10,000 children, there are 8 children who are blind. And because of better neonatal and healthcare facilities, we are now seeing proportion of ROP infants rising over the years. So key pathological features include local ischemia with subsequent retinal neovascularization. So whom to screen? Birth weight and gestational age remains the most important criteria for screening. Screening of ROP in India, we use birth weight less than 2,000 grams, gestational age of less than 34 weeks, Or if it is more than that, then there are few criterias where you screen them, like cardiorespiratory support is there, or prolonged oxygen therapy was there, respiratory distress syndrome was there, or chronic lung disease or fetal hemorrhage, sepsis, exchange transfusion, apneas, or any other high risk factor as described by pediatrician. So in US, the criteria is slightly lesser birth weight or in the terms of birth age, but almost the criteria is similar to what we use in India. So when to screen, the first screening is at 4 weeks. If the infant is less than 28 weeks or less than 1200 grams, then we do the screening at 2 to 3 weeks post-delivery. Now, how to approach the screening? As it is, again, I'm mentioning as it is pediatric ophthalmology for all, what to look for in the screening. So before dilatation, you do a prelim exam, record history with general examination of baby, and then a diluted TP drop can be used where you dilute with carboxymethyl cellulose, or you can just put a drop of carboxymethyl cellulose and put a drop of TP over it. Pupil is always the guide. So what we see, as you can see that I'm using a 28 diopter lens and using my phone to record the pupillary reaction or the pupillary margin. So pupil, if it is reacting, if it is well dilated after dilating, then most likely you will not see anything severe behind. So as you can see in those two pictures, a very frank NVI has developed, and it is not dilating even after four time installation of TP drops. So this can give you a clue right in the start of examination of these babies. So this is again, I'm showing how to record very easily with use of your phone, where you have a coaxial camera and a flash. You can just record it with your phone and you can show it to the baby's mother and parents. So International Committee for Classification of ROP has classified following criteria like severity of ROP, the zone in which ROP is there, extent of ROP, whether retinal blood vessels are dilated or tortuous, whether aggressive ROP is present. I'll quickly go through the stage. Stage 1 is demarcation is seen, then with you see a visible ridge in the stage 2. Stage 3, you see extraretinal neovascular proliferation. There is a plus disease where there is severe dilatation and tortuosity in the posterior retinal vessel. Then there is a pre-plus disease where there is a tortuosity, but still it is not sufficient for it to call it as a plus disease. Aggressive ROP is something which was earlier called as APROP, but the committee has recommended to replace the term and call it aggressive ROP rather than calling aggressive posterior ROP. Stage 4 is the partial retinal detachment. Stage 5 is a total retinal detachment. In stage 5, where the optic disc is visible. Stage 5B, where there is no disc visibility. And stage 5C is something where you see anterior segment abnormalities like anterior lens displacement, marked chamber swelling, etc. So this is how you record a case of ROP in clock hours, in zone, and mentioning where is the disease, so that you can keep in mind where if you don't have an imaging system, this will help you have a proper recording as well. So the classification guides through the about decision making on treatment and screening, when to call them for follow-up, if the immature vessel is present, screening should be repeated, and this is how the classification help you. So management of ROP, I'll not talk much on this. The management includes cryotherapy, laser therapy, anti-VEGF, and RD surgery. Scarring, if the ROP is left untreated, then you see there is a distortion of retina leading to macular dragging, and this sometimes can mimic FEVR or any other old infective granuloma, which looks very similar to this kind of dragging. So indication, in type 1 ROP, we treat these babies, and in type 2 ROP, wait and watch progression. If you are going to treat them, you know the criteria where you know that you have to treat. And if you feel that the baby is in the type 1 ROP, you have to refer if you are not going to treat the baby. So anti-VEGF is getting a lot of surge in the use because of ease of performing the procedure, faster regression of ROP, lower risk of myopia, and less stress on the infant, and faster administration time. So all these things are favoring the anti-VEGF use in recent time. So if you are going to do laser, and if you do the laser, we always avoid general anesthesia for these baby. And there's one small case of marbling which can be seen in excessive crying and fever, but this is very temporary thing. So
Last
if you
30
are
seconds.
if you are having a baby, then what you see for regression, if you see the media is getting clear, pupil fully dilates, no new vessels in the retina, and all these things suggest that there is a regression, and you can actually keep a follow-up under you, and then you can refer the baby later. Look for traction, look for the ridge, look at the feeder vessels, look at the demarcation between the retina and the scar. If it is all flat, then you are going in the right track. So this is a plus disease where the injection was given, and this is a regression. You have to see in those areas where there is the avascular retina. Signs of reactivation can be varied. If you skip areas can also contribute to reactivation. This was recently seen in my OPD where there was a reactivation with severe plus disease. Follow-up can be at 3 or 6 months, 4 weekly follow-up, 2 weekly follow-up, or a weekly or 3-day follow-up. So this was recently shared by my friend where post injection 1 week later you see this picture. So you have to call these babies for close follow-up so that you do not miss any retinal lifting at the posterior pole. So look for RD, strabismus, and amblyopia, myopia. Acute angle closure glaucoma can sometimes happen post laser, and this should be managed urgently in these babies. So this is
sum up?
Yeah, this is strabismus, which you see in gradually. This is what we want to achieve in
Dr. Time.
Yeah. So always look for differentials, and all they matters is what they see in the end. Thank you so much.
Thank you, Dr. Karthikeya, for a wonderful presentation. At least it will guide us to send the patient appropriately, because time is an important factor when we are dealing with ROP. It's a very aggressive vasculopathy and a blinding condition.
I think the reason why we had this particular talk was basically to create an awareness about ROP. The comprehensive ophthalmologist has to remember any baby less than 36 weeker, less than 1500 grams should get a benefit of screening between 3 to 4 weeks. And anything smaller than 1200 grams earlier than 32 weeks should get a benefit of first screening at 3 weeks. Second thing is injection is not the just a one-time treatment. If you opt for a treatment, that particular baby also needs a close follow-up, because reactivation with anti-VEGFs is a not an uncommon phenomenon. Laser is a more definitive treatment, except for APROP and half-zone diseases. And yes, if timely treated, even in stage 4, we can salvage the patient with an ambulatory vision. With this, I think we should sum up this particular part because we are running short of time. Can we move on to the next part of it? I think we are through with it. So
yes, sir.
Yeah.
I would take it over for a second, because this is the first time we are introducing Saransh at AIOS platform across the country. Saransh was a thought process which was involved because most of us are practitioners in the periphery, and many of us do not have an access to the journals necessarily, or even if we have an access, we do not have time or the intention to go into the journals and learn from it. So Saransh was thought as a gist of all these latest published articles which should be implied or should be used in their day-to-day practice. And here we are having the first chef, rather first person to offer you everything hot and sizzling from the fresh from the journals, Dr. Krishna Prasad, a dear friend of mine. So Krishna Prasad, without much ado, you are the first person to start this for ARC. Thank you for so much for that.
Thank you, Prashant. At the outset, I'd like to thank the ARC chairman, my good friend, Dr. Prashant Babu today. Am I audible and visible? The slides are visible?
Yes.
Okay, sure. And the entire ARC team for the opportunity, and really I congratulate for such a brilliant idea, the initiative to bring about the newly published scientific data to the doorstep of comprehensive ophthalmology. I think, like, the disclaimer is, this is not a journal club. So obviously this is not for the faculty who are in the webinar today. It is for a comprehensive ophthalmology. So obviously we will not discuss the nitty-gritty or the complexities of the study. We just tell you the gist of the study and how it can actually change our beliefs, practices, the advice, so that they can pass on the benefit to their patients. So I'll just be basically talking about 5 things that really haunt us on a day-to-day basis. Myopia progression, we have already talked about it. Amblyopia management, and nystagmus is basically a big headache for all the ophthalmologists. and the phakic intraocular lenses in children for the refractive solutions, and the secondary IOLs in pediatric affections. So let's start with the first one. So this is about the myopia prevention. I think there is already 3 to 6 times fold rise in the myopia post-COVID, and we had so this is there are various mechanisms or strategies that have been actually shown, like atropine, outdoor activity, things, glasses, orthokeratology. So there are various things. So this study actually has compared. This is actually a review article which clarifies the advantages and the limitations of the currently available strategies for myopia management. So the conclusion of the study is said that obviously you have to give glasses, that is very important. In addition to that, so if you use atropine alone, so it also showed that, giving a particular therapy in isolation, also combining them. In isolation, atropine showed the highest efficacy in terms of reduction of or the reducing the speed of progression. The moderate efficacy was the DIMS glasses or the peripheral defocus contact lenses or spectacles and the orthokeratology. And the bifocals or the progressive addition lenses or increased outdoor activity had the least efficacy. Obviously, there are things that we can always do is to combine so that if your combined therapy had the most superior effect. So atropine, and if you can combine with the DIMS glasses, and you can also encourage the child to play outdoor, that would be the best case scenario. Here we actually bring in the importance of using the atropine, which has been very well tolerated by children, well documented in the studies, and also very much in practice. We need to reiterate this practice again, and also ask the parents to encourage the child to leave the screen time and play outdoors. And wherever possible, maybe we can use the peripheral defocus contact lenses or the spectacles and add to the myopia progression. So the second study, which I'll be talking about, is something that interests all of us. Is from our own IJO, from my friend Dr. Moria. So this is a trial on the phakic intraocular lenses in the treatment of refractive amblyopia in children and adolescents. See, here you obviously have glasses in higher refractive errors in children. They have prismatic effects. They're not preferred in many times. Contact lenses obviously have their own problems. Orthokeratology has a temporary benefit not widely practiced. But why phakic IOL? Obviously, it has the highest efficacy. It is a cornea independent procedure. It is fairly reversible. We give the full range of even the very high numbers can be corrected independent of the corneal thickness. The child can accommodate normally. Obviously, since it's cornea independent, the highest contrast sensitivity and these higher order aberration. So obviously, we are moving away from the endothelium towards the sulcus and the anterior chamber. And this study had 23 eyes from 21 anisomyopic and isomyopic amblyopias, where they had used the phakic IOL as a treatment of correction of refractive error, basically as a step towards correcting the amblyopia. They had the age group of 10 to 19 years. Obviously, we wait for around 20 plus years for the and this was the thing. And conclusions, basically, I'll be trying to give you, it was a one-time procedure. That was the advantage of the procedure they found. And the contrast sensitivity was unaffected, obviously, with glasses and after phakic IOL. And the mean BCVA increased by 3 lines, obviously, because of the loss of the minification that would happen with thick glasses. It's a very important thing. The child's BCVA actually improved and the UCVA also improved. The good patient satisfaction. Obviously, the patients were happy, the parents were happy, and they did not have much endothelial loss. They did not have much pigment dispersion or the IOL dislocation or the intraocular lens phakic IOL did not dislocate, and very no incidence of glaucoma, even though it was a short study, 23 eyes. But obviously, we need to look at the long-term data that is required because this eye grows. There can be a refractive modifications. Eye may require some kind of a correction later on. And as the eye grows, the white to white can change, the lens vault can change. Most important thing is the vault was basically fine in 1 year follow-up, which is the longest in this study. This is an early report. Obviously, this study requires a lot more, follow-up and the data to say how it can work. But take-home message is this phakic IOL is an option. because most of the people we know how to put an FAB diode in adult or in people about 20 years. This can be an option where the child is not using any glasses, cannot use contact lens, where there's a very severe anisomyopia. This could be an option that we can see. And the third study is about amblyopia. See, obviously standard, as we were discussing just some time ago, that the plasticity, Dr. Sumita was telling that now we believe that it is not only the kids, even the adults or even on an older age group, the plasticity of the brain can still be utilized. So it is now we know that the adult brain is much more plastic than what we believe. So this is actually a study, which is a review article, which basically compared various techniques in the behavioral training as a new treatment for adult amblyopia. It was a meta-analysis and a systematic review. To obviously have dichoptic therapy, video learning as binocular methods, where you don't occlude one eye, you allow both eyes to see with a differential stimulation, and the Gabor patches, just as we discussed, would be a monocular study. So this 27 studies were analyzed in a meta-analysis. They looked at the factors like visual acuity, the type and the depth of amblyopia, the stereo acuity, post-treatment, and the age of the patient. And they found that there were more improvements in an adult amblyopia whenever the initial visual acuity was worse. So visual acuity is actually very good, like 6.
I think the sound is not there.
Yeah. KP, can you hear us or is he lost?
He must have got disconnected.
There is. I'll call him.
I think so. I think we have lost his network. Sunilji, is the network?
Yes, sir. He's gone, actually.
Okay, he's back. Hi,
He's
KP.
back.
Okay.
We had lost you during the third Saransh. Can you hear us, KP?
Can you see the slides? No.
No.
So you need to reshare, please.
Okay. I'll just.
Very interesting.
I'll just come back to this.
Yeah, now
back to the slide. Okay.
Yeah.
Sorry. Okay. Sorry for the hits. So if the improvement will be less if you have a profound amblyopia to begin with, and if there's already a misalignment, so the improvement was much less. So, but there was no call. What was very interesting was the age did not correlate. That is, 20 years or 25 or 30 did not really correlate much. And the type of amblyopia they found, there was no difference in the type of the method used in the therapy and the duration of the therapy. This is something that we need to really look into, because obviously we know that in our practice, anisomyopia actually has a better improvement in terms of treatment of amblyopia in older people. And the minimum duration of therapy, some adult participants could benefit. So obviously, what are the significance? What do we take home from this study is, like, even though it may not translate into actual Snell's visual acuity, but even the adults can benefit greatly just by few hours of behavioral training. That is something very important. Even a one-line improvement and an improvement in the stereo acuity can make an adult eligible for certain. And very importantly, the other aspects of vision, like the stereo acuity, the kind of the tasks, the visual tasks they can perform, obviously improve, which are not actually very tangible or which cannot be basically measured in many times. Obviously, this gives an idea that it is not the improvement in the Snell's acuity alone that will actually tell us about the success. We need to look at the improvement in the visual tasks that they can do much. I think the fourth one is about nystagmus. Nystagmus is something that everybody has. It's a tough thing to actually really decipher and to treat. So far, the treatment of nystagmus surgeries was basically to improve the head posture, increase the visual acuity, obviously in the null point, using the null point, and also probably to improve the quality and the field of vision. So the nystagmus acuity, function extension, NAFX. So these are, obviously we had some conventional procedures. Whenever the patient had anomalous head posture, we would do a Anderson's procedure. For strabismus, if there's an associated nystagmus, we correct the strabismus. And if there is a nystagmus blockade syndrome, we will work on the medial vectors to the tympani. But what if patients do not have all these? If they do not have an anomalous head person, don't have a strabismus, or if they don't have a nystagmus blockade syndrome, so how will we actually treat such patients? So the new technique, or probably the technique which has been revisited, is the 4-muscle tenotomy surgery. Basically, what we do is we basically disinsert the muscle and we attach it in the same place. It's not basically any recession or resection or any change in the attachment. It's basically reattached at the same place. So you have basically, when they did a Kestenbaum-Anderson's procedure, where they actually shifted the muscles back and forth, they also found that just probably the cutting of the muscle also probably created a. That was the Eureka moment. And they had various techniques. They found that it improved the visual acuity, broadened the visual fields, it also increased the foveation time. So the conclusion is, if you can cut the muscles, the recti muscles, and reattach in the same place, what we call as a 4-muscle tenotomy surgery, it can improve the nystagmus, it can improve the vision, the field of vision, as well as the target acquisition foveation. Okay? Now, obviously, we need more studies to evaluate these newer surgical procedures, which is actually much more surgically easier. Anybody who can actually do a basic recti muscle surgery can actually attempt.
Again, he got disconnected.
Again, he got disconnected. Sir, we can't hear you.
Same thing. His network has gone out. It's a red actually.
I think we should proceed then, I believe, with the debates, and we can have the last part of the Saransh after once he joins in. Okay. So I think KP. Okay, KP is back.
Can you hear me?
Yes,
go ahead.
yes.
Last part. We have to sum it up fast.
Okay. Now seen.
Yes.
Yes.
Okay, I think we'll quickly go through this. Sorry for the hitch again. So basically, can we put an intraocular lens in a child and for a toric intraocular lens? Because children do have a very significant astigmatism when you're operating with a child with cataract. And how do we ensure that there is no misalignment, axis misalignment? So basically, they would do an optic capsule. They will do a primary posterior capsule or axis, and this is a 3-piece toric lens which is captured in the primary posterior capsule or axis, and it is rotated in the appropriate axis. So this ensures that there is a centration of the posterior chamber. It doesn't move around. You don't have to do an anterior vitrectomy. So obviously, it reduces the misalignment, reduces the PCO also. Optic capsule is the present go-to technique. Obviously, you have a lacuna. It's difficult to calculate. No formula works well for kids. There is already astigmatism which changes from with the rule towards the against the rule in a due course. Obviously, you will not correct a very small amount of astigmatism. The high astigmatism,
I think he got disconnected again.
Yeah. I think we go ahead. क्या हो गया? आ गया? क्या हो रहा है?
No, he's.
We go ahead with the deep and have the later part.
Oh, yes, sir. I think we can.
He's back again, I believe.
Can you?
Yeah, please.
Yeah. I think so. So this technique, basically, we do not have a long-term data, and obviously there is already a misalignment in the primary surgery. It's difficult to match. So finally, the meridional amblyopia, obviously you can treat in such children with a toric intraocular lens, and toric intraocular lens with optic capture can be considered to correct severe astigmatism. And also, if you can capture them in the posterior capsule, they can actually help us to give a very stable, uncorrected visual acuity. So important. Thank you very much for your patient hearing. I'm sorry for the technical glitches. I think I've been able to convey some of the gist of some of the very important 5 studies in pediatric ophthalmology to a comprehensive.
Thank you,
Thanks.
Dr. Yeah, precisely. That's what I wanted. 5 pearls from 5 articles, and you have done a good justice to the whole concept of it. And I'm sure we will be able to take it more high in the following episodes as well. So without much ado, since we are running a lot of time, we'll have a discussion later. Let's move on to the debate. Rishikesh, you can take over. And Kasturi ma'am also take over because I have to now sign off. I have to flight to catch.
Okay, happy journey, sir. Thank you, Dr. Krishna Prasad, for such a wonderful presentation. Now we go ahead with the debates part. For debates, we have 3 minutes each for a speaker. I'll request every speaker to stop sharing immediately once the presentation is done, so that we can save time and the next presentation can be done. We can have discussion after both the debates. I mean, both the speakers have presented their presentation. So, and we have discussion for every topic. So we'll start the debates now. I request the first debate is on strabismic amblyopia, surgery first versus patching first. So for surgery first, we have Dr. Saranya. We have Dr. Saranya here? Yeah. So please share your screen.
Good evening. Am I audible?
Yes, you are.
Yeah, I'd like to share my screen, please.
Yes, please go ahead.
Okay. So should I start?
Yeah,
Yes,
please.
you have to make
Okay.
it
Full screen. Make it full screen.
Full screen only.
Okay.
Okay.
Continue.
So the topic that I have been given today is the importance of surgery first in cases of strabismic amblyopia. So to proceed, I'm sorry, my slides are not moving. Yeah, okay.
Because they are not full screen.
It needs to be in full screen, otherwise it will not proceed.
You can click on slideshow.
Yes.
Yeah, slideshow.
Is this fine?
No, it's the same thing.
Same.
Yeah,
No
it's not
change.
slideshow.
It's not slideshow.
Just a minute.
Now it's moving at least. Yeah.
It's moving, yeah.
You can continue.
Is it visible now?
Yes, please go ahead.
Okay. So my topic for today is the importance of surgery first in the case of strabismic amblyopia. As we know, amblyopia is a reduction of best corrected visual acuity in one or both eyes, which cannot be attributed to a structural abnormality, and there's usually a difference of 2 lines between the best corrected visual acuity in both eyes. The worldwide prevalence of all kinds of amblyopia is between 1 and 5%.
Doctor, any chance you can make it full screen? Sorry to interrupt. Just go to resume slideshow on the top, which says.
Yes, sir.
Just click on that because we are able to see the entire presenter's view on the slides.
Okay, sir. So
can you just stop share for a minute?
Yes, sir.
Now just click on the green button and then the blue button, nothing else. The green button which says share screen, the pop-up comes. Yes, perfect. Now you can continue, please.
Okay, sir. So today we'll be focusing solely on strabismic amblyopia. The 2 kinds of deviation which are mainly responsible for causing amblyopia are exo and esotropia. Exotropia, however, there's usually an alteration of fixation between both eyes, so the risk of developing amblyopia is much less. Also, the fovea of the deviated eye is competing with the relatively weaker nasal hemifield of the opposite eye, as opposed to esotropia, where the deviating eye fovea has to compete with the stronger temporal hemifield. Therefore, esotropia is more likely to cause amblyopia than exotropia. A review of literature shows certain common points across all studies which favor the importance of surgery in a case of strabismic amblyopia as opposed to the usual idea of occlusion therapy. The first one is, it has been shown that surgery in such cases usually leads to better fusion and therefore stereopsis. Also, the amount of deviation and the duration of deviation is proportional to certain abnormal sensory and motor changes. So these changes keep on developing as long as the deviation is present and therefore jeopardize the results even if the surgery is performed. It has also been seen that the earlier the surgical realignment is done, the earlier the normal binocularity is favored, and this also leads to a long-lasting effect on the final ocular alignment. There is also very rarely seen that bifoveal fixation is achieved in such patients, so there is no rationale for waiting or delaying the surgery. Also, surgery does not affect any motor or sensory outcome adversely, provided post-operatively the amblyopia therapy is continued. One of the studies performed by Lam et al. In 1993 showed that success rates with regards to motor success and sensory success in two groups. The first group had no surgery done for strabismic amblyopia, whereas the second group had surgery done first. So the rates of success in terms of motor and sensory are very comparable. Other points favoring surgery are early surgery reduces the waiting period for surgery, which is usually a time period of anxiousness between parents and children. It also improves the appearance of the child and makes it socially and psychologically more acceptable for the child, because the child is going to school and interaction with peers. If the child is strabismic, it's something that actually impacts the child's psyche as well. Early surgery favors development of fine motor skills and visually directed skills. Also, in one study, it was seen that there was a spontaneous reversal of amblyopia after surgery. There was no need to continue the occlusion therapy after the surgery. Surgery was enough. Also, the shorter the duration of deviation, the more likely the surgery is to be successful. That is, after the surgery is done, realignment will be maintained.
Doctor, it's 4 minutes.
Oh, okay, sorry. So I'll just go over it quickly. Surgery has also been shown to improve cortical visual motion processing, especially in case of infantile esotropia. Sorry. Yes. Also, another factor is that
you'll have to sum up, Saranya.
Ma'am, okay, ma'am. I'll just go to the final slide after this. There is no need for the angle of deviation to stabilize before the surgery needs to be undertaken. And also, with regards to the development of dissociated vertical deviation in infantile esotropia, studies have shown that early surgery reduces both the severity and the incidence. So, early surgery favors stereopsis and fusion, spontaneous amblyopia reversal, the development of motor skills and visually directed skills, the child's appearance, and earlier expansion of the binocular peripheral visual fields, provided, of course, occlusion therapy is continued post-operatively. These are my references. Thank you.
Thank you, Dr. Saranya. Please stop sharing. We will go to the next presentation. That is by Anushri. Dr. Anushri, she will be defending patching first in case of strabismic amblyopia. Dr. Anushri, please unmute yourself.
Yes. Yeah, I'll be sharing my screen now.
Yeah. If you can't, let me know. 3 minutes, please.
Full screen.
Is it visible now?
Yes, visible.
Hello, everyone.
Doctor, it's a presenter. We are seeing the presenter view. You will have to make it
full slideshow.
How do I do that? Sorry.
On the bottom left-hand side, not this. Yeah.
Here?
Oh, no, not that.
So can I interrupt?
The left-hand side, last left-hand side.
Go to display settings.
Go to display settings.
Go to display settings and duplicate slides. Up. There's display setting up. There's written on right on the top. Yeah, go to display settings. Click on the arrow. No, display setting, the right one.
Second one.
The right one.
Next one.
Middle one. उसके बाजू में right side doctor.
Right. Yeah. Oh, it's not going there. No.
Doctor, left-hand side page, the middle one which says display settings.
Yeah, just go up. Just go up.
Go up. Not there.
Above early surgery, there is where it is written early surgery. Above that, there is display settings.
No,
above on the taskbar.
Written display settings.
I have not seen that. Sorry.
Just go left. From there.
Or I can ask Dr. Rishikesh.
Can I? You stop sharing. I will share your presentation.
Yeah, sure.
Okay, you start.
Yeah, I'm not seeing full screen. Yeah. Sorry for the technical glitch. At the outset, I would like to thank SPOCI, ARC, and my mentors for giving me this opportunity. So the development of normal binocular vision is hindered by any abnormality that prevents the brain from processing similar and clear image from both eyes. Next slide, please. There are many treatments of strabismic amblyopia, out of which I will be pitching for patching. Next slide, please. Patching is developed on the concept of neuroplasticity, which refers to the ability of the brain to reorganize and form new neuronal collections. Next slide. Now coming to intermittent exotropia, if there is a refractive correction which is given along with patching, the vision improves, and naturally with the improvement in vision, the control of the exotropia improves, the angle reduces, and many times there is no need of surgery. Next slide. This view is supported by a couple of articles. A very recent article definitely says that part-time patching may improve the distance control in children. Next slide. And not only the control is improved, but there is also an improvement in the stereopsis. When we are pitching in for surgery first, we are always concerned about stereopsis. And if we are getting stereopsis with patching, then nothing like it. Slide, please. This particular study also says that there is definitely a change in ocular alignment also with patching, because treatment-related increase in acuity leads to improved control, and there is difference in the angle, ocular alignment. Next slide. Coming to essential infantile esotropia, this esotropia is seen less than 6 months of age. At this time, it is very difficult to get a reliable measurement. Cover test is not possible. We do the surgery based on modified Krimskis, and there are definitely increased chances of over and under corrections and increased rate of reoperations. And increased reoperation means there is increased risk of general anesthesia to the child. A recent study indicated that patients operated on at a younger age require a higher rate of reoperation. In fact, age has been demonstrated to be the most powerful factor predicting reoperations. Next slide. Also, in essential infantile esotropia, especially, poorer surgical outcomes are noticed if moderate amblyopia is present at the time of surgery. When we pitch in saying that we need stereopsis, stereopsis is improved because of early surgery, these studies say that even preoperative amblyopia was associated with poor postoperative stereopsis. So then the whole purpose of doing an early surgery is lost. Next slide. Also, there are articles which say that you can undergo surgery before the completion of amblyopia therapy, but then amblyopia therapy is to be continued post-operatively. Next slide. Even this study said that amblyopia therapy must be continued post-operatively, but the major barriers, next slide. The major barriers to patching after surgery are, once it is cosmetically aligned, the parents are relaxed, they no longer have any motivation to do patching, the patient is lost to follow-up, and definitely there is a recurrence of strabismus. And honestly speaking, if a single private practitioner sitting in his clinic advises surgery first, this is the scene which will be there outside his OPD. The patient and the parents will run away at the first mention of surgery. So if you provide them with the option of patching, they will definitely follow up with. A Cochrane review has revealed that the optimal time of strabismus surgery is unknown. There are no RCTs currently available, and so we need prospective RCTs to investigate. Next slide. So to summarize, patching of the dominant eye is still the gold standard. Ocular alignment definitely changes with improvement of vision after amblyopia therapy. Strabismus surgery with pre-existing moderate amblyopia is poorer outcome, especially in infantile esotropia. Stereo acuity is improved just by amblyopia therapy, and it is not necessary to complete the amblyopia therapy before surgery. So I would say next slide. Patching bole to, strabismus bole to, patching first. This is the gold standard. Now the jury can pronounce the verdict on this.
I request Dr. Pandey sir for his opinion for this particular.
I think we can't put everything in one basket, because if you look at infantile deviations or IDS as she was talking, I think in IDS she was mixing up alternate patching with the patching for amblyopia. And their alternate patching may help in overcoming suppression and even better alignment. in infantile ESO deviations, as we all know, early surgery is the most important thing. If you do it by 8 months or by 1 year or latest by 2 years. So you cannot delay surgery in those situations. Only thing is when you have older children, maybe there's little leeway. You can wait and do some patching and then do surgery or vice versa, depending upon the condition. But I think we should not postpone surgery to treat amblyopia. Of course, if there is better vision, that is going to help in better fusion, and better visual acuity will help in better fusional mechanisms. But this can continue after that, and then we must keep in mind that most of this strabismic amblyopia could be mixed amblyopia, means there could be anisometropia, there could be a component of refractive component could be there. So this needs to be kept in mind. That aspect is not going to be taken care of in that. And amblyopia, as we know, is a binocular phenomena. As we understand, vision is a learned process like language. So if we don't have proper conditions, that means the alignment, that media are clear, and the wiring in the brain is going on properly, vision is not going to come. So we must understand that it is not the eye which is seeing, it is the brain which is seeing. So all that circuitry has to be maintained. And if the alignment is not proper, the treatment of amblyopia is also going to be not a perfect thing. So I think we should treat deviations as and when they can be done, and at times early surgery is important. Of course, intermittent, the infantile deviations and IDS will have different kind of temporal issues when to do surgery. We are not going to that, but we should not, I think, defer surgery as far as possible for the sake of treating amblyopia. That's my point.
Thank you, sir. Thank you for your views. I think we'll move to the next debate, which is pediatric cataract surgery, PPC anterior vitrectomy versus pupillary, IOL capture. First, we have Dr. Vivek Varkat, who will be defending PPC with anterior vitrectomy. Dr. Vivek, please.
Yeah, hi, good evening to everyone. So basically, I'm going to take for, the PPC and AV. So I do not have any financial disclosure, but I have a disclaimer. So all the contents in this presentation, even those based on true or proven information, are not meant to cause any grief, harm, or discomfort to any one of the group or, the surgeon in this audience. It is used and presented in a course and a humorous way on the name of, the creative freedom. So basically, my opponent believes that, the IOL capture is the best in pediatric cataract surgery. But however, I would prefer, the most time-tested surgical procedure, which is called as PPC plus anterior vitrectomy. It is far simpler, safe, and, the reproducible than the IOL capture. So as we know that, the procedure of choice must be decided upon on an individual basis. However, some favor one over the other, definitely with the support of evidence. So basically, I'm trying to show this video because I do, negotiate the IOL the way you can appreciate in this video, and then take the vitrectomy probe underneath the IOL and start doing, the PPC and AV. So to introduction, visual axis opacification is the crux. That is what every pediatric ophthalmologist is worried about when they take these children for surgery. So what are the risk factors? I think intraocular IOL, their types, designs, young age at surgery, increased inflammation, not performing PPC and AV, or sometimes the small capsular axis. So I think the VO remains the most common indication for second surgery in children, if at all we would look at into the literature. So now why I said it's time tested, because almost more than 2 decades, if you look at these major the journals with a very solid evidence that probably the PPC and AV is the standard of care, even at this time point, 2 decades after that has been very much proven. So what are the advantages? It has a dual advantage of not allowing the lens fibers to grow on the surface of the capsule and beyond the margin of PPC. The depth of entry chamber is increased when you do a PPC and AV, so that prevents the IOL rubbing onto the iris and thus the inflammation. The anterior vitreous face can form a scaffolding for the lens epithelial cell, and hence PPC AV can reduce the PCO incidence. And the rim of PPC itself, it contracts the force of rupture towards the periphery. And I would keep this little bit on a lower tone, like the incidence of retinal detachment can be decreased when you choose this method, which can occur after laser capsulotomy when you do not do, and then you need to do post-operatively the yak cap. So this is what the literature support. I think that is very much in place. If you look at this article, what we have reduced from almost 75% to 11% with anterior vitrectomy on follow-up of 12 to 36 months. This is our own Dr. Vasavada's, the paper which talks about, the anterior vitreous fibrosis in 70% of the eyes in the group where, the vitrectomy was not chosen. Our own experience, we have shown that it's quite useful with no complication and the VO rate of less than 20%. So what are the disadvantages, or I would say the limitations? I think the optic capture has a learning curve for a novice pediatric surgeon, cannot be performed in all type of pediatric cataract. ACC and PPC should be of adequate size, otherwise you would end up with a possibility of disenclavation, friable posterior capsules, PC with plaque, PC defect pre-existing, just like in posterior lenticonus, it's very difficult or to attempt the capture. These are the other ones. When you have a small pupil, there is always a concern regarding IOL exchange, shallowing of anterior chamber during any step that would lead to the vitreous prolapse into the anterior chamber. And then small PPC also offer challenges, especially in older kids where capsule elasticity is less and the chance of extension. So I think to conclude, it's a time-tested, simple, very much reproducible, can be performed in all types and situations in pediatric cataract, best choice for the novice pediatric cataract surgeons. And as the phaco and vitrectomy machines, they are evolving in the technology, I think PPC and AV has become a safer and effective procedure in pediatric cataract surgery. Thank you. Thank you very much.
Thank you, Dr. Vivek. I think we will move on to the next presentation. Dr. Jaspreet, he will be Dr. Jaspreet Sukija. He has done a lot of IL capture. He will be presenting sharing his opinion about the procedure.
Thank you, Sposi and ARC for this opportunity. Yes, I will be putting forward some of my points which were called as disadvantage from my dear friend. But for me, those would be the advantages. So I would be discussing why we should go on for posterior optic capture of the IOL in children. So what is the main aim? The main aim is to prevent or minimize visual axis of obscuration and inflammation, as has been rightly pointed out. So that is what, because we don't want amblyopia in children. So conventionally, as has been shown that it is the PPC plus anterior vitrectomy plus IOL in the bag. But here what we are doing is PPC with optic behind the PC and haptic in the bag and no anterior vitrectomy. The concerns with routine surgery are that the rexes, both anterior and posterior, have to be appropriately sized. So the anterior rexes has to be smaller than the optic of the IOL. The visual axis of opacification rate is 30 to 40% because of various factors highlighted. There are issues with vitrectomy. You might cause a vitreous tag coming out, which will lead to decentration, maybe a retinal detachment. And what about small children, infants? Are you sure that the bag is big enough to accommodate the IOL? So those are the concerns. But our main thing, why we want to do a capture is because of this, the visual axis opacification. So why do we need to do this? What are the advantages we need to keep when we keep the vitreous intact? Without an anterior vitrectomy, what happens is basically it is a barrier between the anterior and the posterior segment. So why disturb it? And we are still not aware what consequences it can have later in life. How much is the adequacy? Again, we don't know. We have to put triamcinolone on to see how much have we identified. Then strands of vitreous can come in the anterior chamber. Enlargement of the PPC can occur at the time of vitrectomy, making it impossible to implant the IOL in the bag. And this was one of the studies in the American Journal of Ophthalmology where they said that when you start removing the vitreous, it makes the environment less hypoxic and causes a concern of glaucoma. So in an infant where the trabecular meshwork is immature, the chances increase because of this damage when you do an anterior vitrectomy. So I'll just show you what posterior optic capture is. So basically you have to make a rexis pretty much as you do in a normal case. And once you made a nice round rexis about 5 millimeters, doesn't matter, the size may be larger or a little smaller as well. what happens is you make a posterior rhexis, which has to be larger. Yes, there is a learning curve here. So this rhexis has to be larger for the prolapse of the IOL behind the posterior capsule. But yes, no anterior vitrectomy is required in these cases. Just fill the viscoelastic in the back and implant your IOL. That's the rhexis. You can see the posterior rhexis is larger, and if we go forward, if you can see here, we put it behind the posterior capsule and you can see the oblong margins of the capsule. This shows that it has been posteriorly captured. So we've done this without an anterior vitrectomy. So what goes on? This is the evidence what you had come over the years. You have various papers. Basically, what we have done a randomized study over it. And so what we found is, why do we do capture? Because it's a promising alternative. Why it is a promising alternative? Because of significantly less inflammatory response. This is evidence-based. The bag is sealed. There is no visual axis obscuration and no proliferation of the lens epithelial cells. The risk of geometric centration is decreased because you lock the IOL. The optic-haptic junction is locked at the posterior capsule. There is no change in effective lens position because the optic is behind the posterior capsule. As was rightly pointed out, toric IOLs have been implanted because there is less chance of rotation. Now, why? Because the IOL has been locked. There is low incidence of capsular contraction because the optic-haptic junctions again prevents the capsule from contracting. It avoids the ill effects of vitrectomy. We have so many of those. The operating time is shorter because you're not doing a vitrectomy. And of course, you have a growing bag. So what you want to use is the Burgess space, which is behind the posterior capsule. So if you see this is one of the pictures from the randomized study. It's a 4-year follow-up, and these are the eyes of the same patient who had bilateral cataract. You can see the IOL in the bag after 4 years. What's happening? With a good rhexis, anterior rhexis, with a good posterior rhexis, there is still lens epithelial cell proliferation, which might reach the center over the years. But if you see the optic capture, when no anterior vitrectomy was done, remember they were done in a period of 1 month's time. You can see the good sombering ring and a golden visual axis. All your epithelial cells have been sequestered inside this capsule. So I leave it to the jury. What surgery would you prefer? Thank you so much for hearing.
Thank you, Dr. Jasprit. Thank you for a wonderful presentation, both Dr. Vivek and Dr. Jasprit. We have Dr. Subita Agarkar. Your comments, madam, for this.
I think both the people have presented their view, and if you see, they are basically, both of them are saying the same thing. And if I were to quote Jasprit's article where he compared one eye with capture, there were VAO rates and the complication rates were same. They have just used one eye for capture and one eye, their own publication. There was no clear superiority of the capture over an anterior vitrectomy done from their own paper. So if you say visual axis opacification is your main concern, both the techniques work reasonably okay with equal number of, both require a little bit of learning curve, but I think learning curve is slightly more for optic capture. And this is my personal experience. Second thing, my problem with optic capture is that it requires a certain type of intraocular lens. You cannot use each and every type of intraocular lens, which you cannot use, for example, a PMMA lens for capture. Second thing, if you happen to lose the bag, then you have to probably capture, you will have to abandon the capture because you will not. While with anterior vitrectomy and all, you can still ensure some amount of good centration of the lens. So at the end of it, both the techniques are comparable, and I think both should be a part of armamentarium of any pediatric ophthalmologist who does wants to do pediatric cataract surgery, because there is a role for both, and at the end of the day, you should stick to what works best in your hands and what works best with your machines, your availability of the resources, and what works best in your hands. We can debate, but I think if you look at purely an evidence in terms of VAO, both have performed equally well. Thank you.
Thank you, ma'am. I think we will go to the next presentation. We have Dr. Aparajita Shinde. We have a debate on acute sixth nerve palsy versus, no treatment versus injection Botox. So, Aparajita, I'll share her presentation.
Yes, Dr. Rishikesh, please share my slides.
Doctor, can you just stop share for a minute? First open your presentation, then do the scale. We can see the, yeah, first open the presentation, then do the screen share.
Okay, 1 second. Yeah, no, I will.
Yeah, just put it in slideshow mode. Yeah, thanks.
Yeah, start.
Good evening, everyone. Thank you all for giving me this opportunity. Next slide, please, sir. We know that the abducens nerve palsy is the most common ocular motor palsy in adults and second most common palsy in children. The potential etiologies are different in both childhood and in adult group. Treatment of acute abducens nerve palsy include detailed workup to rule out any serious neurological condition, and once this is ruled out, watchful monitoring is done. Other options for managing the symptomatic diplopia includes botulinum toxin injection, occlusion therapy, and frenal prism. Next slide, please. Now, today in this debate, I would be talking in favor of no treatment in acute sixth-nerve palsy. Various case series have already reported that isolated sixth-nerve palsies due to various etiologies have excellent spontaneous recovery rate of around 70 to 80%. Sixth cranial nerve palsy usually recurs spontaneously once the nerve restores its function within 3 to 6 months. Here, underlying or systemic conditions are to be treated primarily. In some of the cases of sixth nerve palsy, such as due to viral infection, this resolves spontaneously and does not require any treatment. The sixth nerve palsy resolves on its own after the natural course of the disease is over. Next slide, please. Now, there are various drawbacks of botulinum toxin, such as most common side effects reported are ptosis and acquired vertical deviations. Other side effects include pain, swelling, or subconjunctival hemorrhage at the injection site. There are various vision-threatening complications such as infection, globe perforation, retinal detachment, which are rare but possible. Also, injection botulinum toxin is not recommended in pregnant women and in lactating mothers. Next slide, please. Now let's see what literature says. There are various various studies which have compared these two groups, but I would like to quote these two studies. One prospective multicenter study conducted by Holmes et al. In acute traumatic palsy have reported that there is high and similar rate of recovery in patients who were treated with botulinum toxin within 3 months of injury and in those who were treated conservatively. The risk ratio was also similar in both the groups. The risk ratio of recovery was similar in both the groups. That was around 1% with the botulinum toxin injection. In another prospective randomized trial in acute unilateral sixth nerve palsy due to various miscellaneous causes, it was found that there was a high recovery rate with conservative treatment, that was 80%, and in botulinum toxin injection, it was 86%. The difference was not statistically significant, and therefore it was recommended that prophylactic botulinum toxin injection is not necessary. Next slide, please. Therefore, I would like to conclude with these remarks that acute isolated sixth nerve palsy have high rate of spontaneous recovery, and prophylactic treatment with botulinum toxin is not essential as recovery rate is similar in both conservative group and in the botulinum toxin injected group. Thank you.
Thank you, Dr. Aparajita. We have with us Dr. Sandra. She will be defending botulinum toxin now.
Thank you. Am I audible? Can you see my slides?
Yes, yes, please.
Yeah, so I'll be talking about the application of botulinum toxins. So let us first look at the application in diabetic mononeuropathy. So the opponents say that it's controversial due to the incidence of spontaneous improvement with time, really. So let us look at some hard facts. This is a study which has been published in this journal I in 1995, where they looked at 213 patients with unilateral isolated sixth nerve palsy and say a report 78.4% spontaneous recovery. But look at the time involved. It takes 8 weeks for 36% of the patients to resolve. It takes almost 6 months for 73.7% of the patients to resolve. So a patient comes to you and says, do something, I'm seeing double since a week and is highly distressed. So what do you say? Don't worry. If you wait for a month, it will resolve. And what are the options that we have in the interim? We have patch, we have occlusion glasses, but just think about the patient's life in this time period. Whether he works or whether he is having, like a time out with friends, or whether he goes to the market. It's so distressing with the diplopia. So, and even if you look at a cup of coffee, there's past pointing and you cannot really enjoy it. And look at the road, what it looks like. So the patient comes back again. I lose my job. Is there no other way? How many times have we seen this scenario? And then there is, of course, an option. What about an injection? It may make you feel fine in a week if it works. And there goes a sign of relief. So who benefits most from botulinum? There is a subset of patients who are intolerant to diplopia, and they are suffering because of inability to perform routine work and work-related activities during this waiting period, are the ones who will be most benefited. So think that you are having diabetes and you are going to get diplopia from tomorrow. Would you rather wait for 3 months for spontaneous resolution? Prisms can help to alleviate the symptoms only in the straight gaze. It's not very effective in treating the incompetence in lateral gaze. So this was a study we had done, published in IJO in the year 2019, where we looked 31 cases in our institute. 58% of the subjects had incomplete palsy at presentation and 42% had a complete palsy. Mean dosage of injection was 5 units and mean follow-up period is 2 months. Just compare the baseline head posture, primary deviation and abduction limitation at baseline with the improvement you see at 1 week, 1 month and 2 months. Even the values at 1 week are highly significant, both clinically and statistically. There's hardly any phase turn, primary deviation or abduction limitation. So why would you want to wait? 83.9% of the patients were fully treated with Botox. So early injection definitely helps in alleviating symptoms, restoring function and quality of life, and reducing the need for further interventions in future. And what about trauma? There was another study published in Eye Journal 2005, where the reports of recovery rate in Botox group significantly higher than the conservative group. And also the final angle is larger in the conservative group than the Botox group. The abduction deficiency improvement again better in the Botox group and then in the conservation group. This is one of our patients who just came. You see the date, November 29, 2023. The patient is an 11-year-old boy who had a trivial trauma. Some other boy hit him at school and he got a full total 6-nerve palsy of his eye. He couldn't go to school. He couldn't write his exam and the parents were highly distressed. So we offered him Botox and within 10 days, he was fine. If you look, he's having orthophoric stereo 60 with full abduction improvement and the quality of life improves immediately. And if you look at botulinum toxin for cases like nasopharyngeal carcinoma, where there may be a significant risk of prolonged GA, again, there was a study published in Eye in London 2018, where they report a statistically significant reduction in mean deviation after the last injection as compared to presentation and resulted in a pretty good improvement in the patient's quality of life with just an injection. So in my opinion, it is definitely a better choice because it's non-surgical, faster rehab, aids LR recovery and prevents MR contraction. Thank you.
Thank you, Dr. Sandra. We have with us Dr. Jitendra Jethani. I will request his expert opinion on this particular debate.
Thank you so much, Rishikesh. I think with Botox, I would at the beginning I would say that there are more than one ways of doing the same thing. The only I would agree that it is not really about the final recovery. There may be some advantage that you are giving Botox because MR contracture would not occur. So definitely there will be some benefit in the final outcome. Regarding the diplopia, I think primary position would definitely improve, but I don't think the secondary positions will completely improve and the abduction will completely improve. Although there will be some improvement in the abduction. So definitely Botox aids your recovery is faster. The quality of life is definitely better because you are improving the patient in primary position. Now, the point is whether, in a setup in private practice, it's pretty expensive. The cost of Botox is almost similar to, we don't get isolated LR palsy every second day. So, quality, you can't keep reusing the same vial. So the quality of life does make a difference. But in some patients so you have to give an option that this is definitely a good option. We can do it in acute 6-nerve palsy. but not a rule that, if you don't use Botox, everything is lost. So in my opinion, it would be like it's a good option. You can use an option, but not mandatory.
Thank you, Dr. Jitendra, for your expert opinion. I think we'll move on to the next debate. We have a couple of debates remaining now. The topic is on intermittent divergent squint, non-surgical treatment versus early surgery. So we have Dr. Snehal Thakre. She will be defending the non-surgical treatment for IDS.
Yeah, Dr. Rishikesh, can I say something? Just a sentence.
Yes,
like
yes,
in
yes.
children, I think if you have 6 now palsy in children, less than 4 years also, they are prone for amblyopia. So in these cases, we need to look at them a bit differently, that we should look at that aspect also. Otherwise, in that period, he may go amblyopic, and that may be a difficult situation.
Just a quick word that in children, you also need to give general anesthesia. You have to look at that aspect also. That's also important as it is to look at amblyopia, which you can give the patching.
True.
So, Dr. Snehal, please. Yeah, your slides are visible.
We can't see Snehal.
Yeah, the slides are visible.
Yeah.
Put it on slideshow, please.
Again, it is the
mute. Yes. Now, fine.
It's the
I
slide.
think yes.
Yeah.
Yes. So I'm sorry for the glitch. Good evening, everyone. I thank Shubhangi ma'am and Dr. Rishikesh for this opportunity. Today, my topic for the debate is non-surgical management of intermittent exotropia. Is there a role? Yes, that's the way. Actually, in management of intermittent exotropia, there are more questions than answers. And many might say that the answer is surgery, and that too earlier, the better. But surgery has its own set of problems, frequent recurrences, dreaded overcorrections, and others. So, and one thing which we have to know is that having IXT has a distinct advantage over ET for a patient, that is the presence and maintenance of stereo acuity. And this is the reason to maintain the stereo acuity is the reason given by the propagators of early surgery. But you should know that low deterioration of stereo acuity has been seen in patients who are followed over a period of 2 years. And at the same time, nearly half the children with IXT show marked variability in stereo acuity over the course of a single day. Stalwarts have shown us over the years that younger the age at surgery, poorer is the sensory outcome, and there are more chances of post-op recurrences. So here we take a moment to pause and think maybe doing nothing often leads to the very best of something. Many observational studies have shown that maximum patients remain the same, few recovered and few deteriorated. Now, once we think about IXT, is control important or angle? Now, control decides whether to operate and the angle decides how much to operate. And studies have shown that IXT has control is more important than the angle of deviation where the surgical decision-making is concerned. Now, here is where the role of non-surgical management lies. Through these various mechanisms, it shows definite improvement in control and decrease in the angle magnitude. So very simple, it begins with simply optical correction, which improves the sensory and motor fusion and gives a more corrected angle of deviation. Or you can give over-minus glasses, which stimulate accommodative convergence, improve control, and decrease deviation. Prisms also aid in sensory fusion by shifting the target closer to or onto the fovea. Then there is patching or occlusion, which is a cost-effective, easy way for the non-surgical management. It improves control, decreases, and gives a reliable angle of deviation, may change the character of deviation from a tropia to a phoria, and improvement. There is a definite improvement in stereopsis for near. There is said to be that there can be a conflict between parents and children because they don't want to wear the patch. But a study by Holmes et al. Has shown that the health-related quality of life remained the same whether the child was observed or patched. And then there is orthoptics, which is a little bit difficult for very young children, but still can be done, which improves sensory fusion, hence success rate of surgery when both are combined. As a matter of fact, the cumulative probability of suboptimal surgical outcome is far less when both these modalities are combined together than when surgery is done alone. And lastly, I would like to share this study from Dr. Kushner in which he has followed up 279 patients for over a period of 20 years, where he says that, and he has concluded that part-time alternate occlusion and over-minus spectacles with prisms where needed can defer the need for surgery in large percentage of patients and maybe even curative in some. So why should the child be subjected to all these complications by doing an early surgery to maintain stereopsis when all these other non-surgical modalities can achieve the same, that too painlessly? So here I rest my case. Thank you.
Thank you, Dr. Snehal. So we have Dr. Saranya with us. She will be defending early surgery in case of IDS. Dr. Soumya, please. So, Dr. Soumya. Please.
Yeah, good evening, everyone. First of all, I'd like to thank all the organizers for having given me this wonderful opportunity. So Warren Buffett said, I wish I learned this when I was younger. So I'm going to be talking about early surgery in intermittent exotropia. So disclaimer, this debate is being done in good humor. No feelings and sentiments are meant to be hurt. So we've heard the adage, the early bird catches the worm. The 5 a.m. club, early to bed, early to rise makes a man healthy, wealthy, and wise. So key reasons why we want to treat strabismus. Cosmesis, we want to avoid sensory changes, especially amblyopia. We want to attain good stereopsis and binocular balance. So surgical options, we know you can do a bilateral recession, or you can do a lateral rectus recession with medial rectus plication or resection. So in what way do non-surgical treatments help? Okay. So my formidable opponent said that, it controls the strabismus, but studies say that it does not necessarily treat the degree of strabismus. Okay. She also said that it helps us defer surgery, which anyway in a lot of situations has to be done at a later date anyway. So deferring it might make an intermittent strabismus constant, therefore reducing the stereopsis. So what does literature say? So in American Journal of Ophthalmology, Repka et al. Say that younger aged surgery, better outcomes. So even younger aged surgery between 3 to less than 5 years is associated with better surgical outcomes. Of course, further RCTs need to be done, right? Again, a surgery done by Saho et al. Says that even surgery done less than 4 years of age may present even better motor results. Postoperative stereoacuity in young children believed to be worse could be just because they couldn't do the stereoacuity well enough. Again, in JAPOS, it says that sensory results after lateral rectus muscle recession for IDS could be done even before 2 years of age, and this responds well to surgical treatment and high-grade stereopsis can be achieved. So this is my experience. An 18-year-old exotropia since as long as she can remember, worse when she's tired or not concentrating, and stereopsis post-surgery remained the same. 16-year-old intermittent exotropia, but ended up becoming undercorrected post-surgery. This child with sensory deafness and exotropia, wouldn't we want to give her the advantage of surgery at an earlier date because she has to deal with not only deafness, but also squinting? So my opponent says that you cannot measure strabismus at a younger age, but you can't measure the psychosocial impact of it as well, isn't it? Overcorrections at a younger age, fine, modify the measurements. You can do a 1 mm less in younger age groups as per your surgical tables. Patient has good stereopsis, she says, so why bother? But 55%, studies say 55% can have monofixation syndrome. And sensory imbalance may not be accurately measured by tests of stereopsis. So there are studies that say that binocular balance may not always be measured by our usual stereopsis tests. And Maru et al. Say that microtropia occurs when operated more than 11 years. We know that the secret to care of the patient is in caring for the patient, and we need to respect our children's views too. So there are a host of studies that say that children's quality of life, especially at school, like Dr. Saranya said, is better post-surgery. And there is a discrepancy between a parent's perceived QOL versus that of a child. The parent may not actually have insight enough to see how badly the child feels at school because of his IDS. And there are obvious studies which say that, such children have poorer psychosocial functioning, poorer interpersonal relationships, and lower self-esteem which can actually work on them later on in life. And successful strabismus surgery have positive effects on psychosocial functioning. In fact, one important thing that was seen in this study by Mrutyunjaya et al. Says that subjective satisfaction and psychosocial benefits occurred even in cases deemed objectively unsuccessful. So let's not bother about success in just terms of the number of PD. There are a lot of aspects to success when it comes to strabismus surgery. And again, corrective strabismus surgery improves the HRQOL scores in children with IDS and their parents. So, studies say that there is little change in the mean angle of deviation from initial to final visit for the group, with a nearly chance occurrence for the distant deviation to progressively worsen or improve. So when it's going to stay the same, why not just go ahead and operate? So early surgery, early cosmesis, early surgery, better stereopsis, early surgery, less amblyopia, early surgery, better quality of life, intermittent exotropia, early surgery. I rest my case. Thank you.
Thank you. Thank you, Dr. Soumya. I request Dr. Shubhangi Bhave madam for her expert opinion.
Both the speakers have put forth their views very strongly. I feel that both of them have spoken very well, but it's not just early surgery, as Soumya said. It is early surgery with a good result. That matters. And so in these cases, in cases of intermittent exotropia, when you are assessing a small child, sometimes it may not be... Rishi, can you just stop sharing?
Yes.
So it is not just, we need to assess certain aspects where we need to assess the far distance exotropia in order to get a good correction. So in order to get all those things, and if you're confident that all your readings are perfect and the dosage of surgery is good, then maybe you can go in for an early surgery. Otherwise, it is more of a monofixation and less of stereopsis post-surgery than before surgery. So again, it depends on how frequently the child is squinting, again, how frequently he is dissociating, and not all the cases can be treated by same logic. So that's it.
So with this, we come to the last debate of today. It is on myopia. It is, lifestyle modification, which I will be defending versus diluted atropine or low dose atropine by Dr. Anthony. So my slides are visible, right?
Yes.
Okay. So basically this debate is, we cannot compare the role of lifestyle modification versus diluted atropine, but I'm going to highlight the role of lifestyle modification not only in onset, but also progression of myopia. Myopia control measures have been described by, there are many ways myopia control measures have been described, but with time we have realized that these four are the principal ones which we can use in clinical practice for controlling the myopia progression. So lifestyle modification includes outdoor activities which prevents the onset, but it does not prevent the progression of myopia. It reduces. It also implies that we reduce the near work, especially screen activities like mobile and tabs, with adequate room illumination. Studies have found that there is no role of nutritional supplements in onset and progression of myopia. The advantages of lifestyle modification is that it not only helps in onset of myopia, but also for overall health, overall healthy lifestyle. But the disadvantage is that studies have found that they don't have a role in arresting the progression of myopia. And also it is difficult to follow them for a longer period of time. So which children you should advise lifestyle modification? Actually for all children, but especially those who are at high risk are children with parental myopia, females, more than males, especially in age group more than 9 years. preterm infants, and also in children who are more into education. Especially, it has been found that children who are staying in urban areas are more likely to have myopia compared to those in rural. Also, studies have found that time spent outdoors they reduce the increase the chances of myopia with time. And it has been recommended that at least 1 hour of outdoor activity in sun and fresh air is recommended. Studies have found that restricting the outdoor activity by 1 hour per week can increase chances of myopia by 2%. So recommendation is also for indoor lighting of around 100 to 500 lux illumination. Behavioral changes like adequate room illumination, adequate distance while reading, adequate posture, especially on table and chair, and frequent breaks has been recommended. As earlier highlighted, there is no role of nutritional supplements here. We conducted a study, a comparative analysis of the same group of children in pre-pandemic versus pandemic period, just to see whether increased exposure to digital devices, whether that increases the progression of already existing myopia. And we found that especially in females, we had 58 children here. This study was presented at WSPOS. We found that especially in females, and in patients between 11 to 15 years, as in this graph shows, and in females, the difference was statistically significant. The difference of myopia progression in pandemic versus the pre-pandemic period. So with this, we concluded that there is an increasing trend of myopia progression during pandemic period compared to pre-pandemic, which is more in females and in age group between 11 to 15 years. And also, we found that children who are already on diluted atropine, also the progression was more compared to pre-pandemic period. So, lifestyle modification not only has a role in onset of myopia, but it can work in tandem with other myopia control measures like diluted atropine in reducing the progression of myopia as such. So we want to conclude by saying that lifestyle modification is very important, because myopia, like previously it was thought to be a genetic disease, it is not like that. It is a lifestyle disease. So lifestyle modification definitely have a role, and they can work in as a complementary to other myopia control strategies. Thank you. Dr. Anthony?
Yeah.
Yeah. We have Dr. Anthony with us. I think you need to unmute Dr. Anthony.
Yeah, am I audible? I'm
Yes.
trying to share my screen. The green button, then the entire screen, share.
Yes, now I think you
make a slideshow.
Yeah. Is it visible?
Yes.
Yeah. First of all, I thank Cozy and ARC for having me here. And I thank my previous speakers, Dr. Shruti and Dr. Krishna Kumar sir, for Krishna Prasad sir, for making my talk easier. And above all, I thank Dr. Rishikesh for taking a topic which is hard to defend for himself, and for having already given me a lot of points for the success of low-dose atropine topic, and giving me a little easier topic to defend. So atropine has been used in medicine for centuries, and even for the treatment of myopia, control of myopia, it has been used even since the 19th century. So a recent Cochrane article classifies the use of atropine for myopia as high dose, moderate dose, and low dose. Low dose being defined as less than 0.1%, which includes 0.05, 0.025, 0.02, and 0.01 percentages. And I am going to talk in favor that low dose atropine is definitely favors myopia progression control compared to environment modifications alone. So we all know the previous landmark studies of use of low-dose atropine in controlling myopia. The ATOM-2 study, the LAMP study first phase, LAMP study second phase, and the CHAMP study, which also says that the proportion of patients who progress less than 0.50 diopters myopia is higher when they use atropine 0.01%. Not only in Western population, even in the Indian population, we have a sufficient number of studies, like the study done by Rohit Saxena sir, and we also have this consensus statement by the Mumbai group of pediatric ophthalmologists, which came up even in 2019. So, and the very own SPOCI guidelines, which say that low-dose atropine does have a role to play in controlling the myopia progression. And this is one study where it's done not by non-ophthalmologists, done by community medicine people. They also attest to the fact that low-dose atropine helps. And from controlling the myopia progression, now the use of atropine for controlling myopia in pre-myopes has even been studied now, and it has also been published. So this forest plot taken from the Frontiers of Public Health journal also shows in a succinct way how atropine, the studies which use atropine for control of myopia progression, you can see that definitely the patient in the control group, that the people who don't use atropine have a higher rate of myopia progression compared to those who use atropine. On the other hand, when you look at the environmental modifications, we can see that when you see the randomized control trials, yes, it is helpful, but how much helpful? The amount of diopters that it controls just by using environmental modifications is far lesser than what you get with atropine. And whether it is clinically significant is a question to answer. And SPOSY guidelines clearly says that based on the available evidence, it's clear that outdoor time prevents myopia, but we cannot say that it is helping in progress, stopping the progression. And above all, the specificity of environmental modification and explaining to the patients how much of light they should be in, and all that, and applicability in different weather settings, different climatic scenarios is definitely a question. It's definitely a question. So coming to the fact that low-dose atropine is more effective than environmental modifications in controlling myopia progression. Thank you.
Thank you for a very nice presentation, and we have published guidelines, and I think what we need to look at is the pre-myopia. I think we need to identify those children who are going to be moving towards myopia. I think that's the area we need to strike because the incidence and prevalence is rising. So I think we in that outdoor activities are very important. I think, of course, what you rightly said that they may not be very effective in all these situations, but we have seen rural versus urban, and all those issues are there. So there is less myopia in rural population as compared to urban population. So all those evidence is there that outdoor activities do help.
Dr. Shreya would like to comment.
Thank you. Thank you, Dr. Shubhangi. And
oh, I'm sorry.
It's okay, sir. You are senior to me. You can. So
the
only thing, there is no debate at all in this topic. And we all know all kinds of myopia progression alternatives available to us. The lifestyle modification, as Dr. Rishi himself said, it cannot be the only superior treatment. It has got definite added advantage if you are combined with other treatment. And as we have already seen, the spectacles are too costly, the contact lenses are not available, and only lifestyle modification doesn't work. Atropine works very well in all, and nowadays in market 0.5% atropine is also coming up. So that will be a
0.05 you want to say. 0.05 you want to say.
Sorry.
Yeah.
And it should be added with lifestyle modification. I would say that lifestyle modification is the important thing if it is added with other modalities. Thank you. Thank you so much.
Thank you, Dr. Shreya. Sorry for the interruption.
I know that it's you who have initiated this. So.
Myopia is very challenging and very exciting and enticing.
Yes,
so I think
you have worked hard on that. Yeah, you have worked hard for that. Yes.
Yeah.
I think Rishi, can you conclude with this? We come to the end of today's session.
We are really grateful to ARC and
ARC, we are grateful to
Thank you so much.
I think I would like to thank AIS, ARC and SPOSY for this wonderful meeting. I think we comprehensively covered the entire spectrum of diseases in pediatric ophthalmology, and I hope this session will help the general ophthalmologists and the postgraduates to give justice to their pediatric patients and treat them on time, because time is an important factor when you are treating cases of pediatrics. So I think I would like to thank all the eminent speakers for their wonderful.
I would like to thank Dr. Prashant, and I think we need more such interactions and discussions. I think that is required to enhance this awareness amongst the ophthalmologists and general public.
Thank you, sir.
Thank you.